Welcome, future nurses. I am Dr. Isa Osman, and you're watching Logical Pharmacology. Today, we are tackling the biggest hurdle on the NCLEX, pharmacology. My goal for the next 2 hours is to help you stop memorizing flashcards and start understanding the actual logic behind medications. When you know how a drug works, the answers map themselves. This crash course is broken into 10 complete modules, covering everything from hemodynamics and antibiotics to maternity and oncology. At the end of each module, we'll run a next-gen prioritization check to test your clinical judgment. You do not need to scramble to take notes today. The exact study guides and next-gen traps you will see on the screen are all from my complete pharmacology cheat book. If you want to download it to highlight and follow along, click the first link in the description. Let's get right into Module 1, Medication Reconciliation and the Rights of Administration. Before any of the high alert content in this course matters, every single dose has to clear these checks first. Verify the core rights, the right patient, drug, dose, route, time, and documentation. For high alert medications like insulin or heparin, 2 registered nurses must independently calculate the dose and verify the 5 rights apart from each other before administering. That independence is what prevents confirmation bias from letting an error slide through. Transitions of care, admission, transfer, discharge get tested heavily. When medication lists don't match, follow a clear source hierarchy. First, ask the patient and family what they physically take at home. If the patient is confused or an unreliable historian, ask the family to bring in the physical bottles, the classic brown bag check. Never rely solely on a previous admission list in the electronic health record. That list is outdated the moment the patient leaves the facility. 2 traps worth knowing here. If a post-op order omits a home anticoagulant like warfarin, don't assume it was discontinued permanently. Maintenance therapy is frequently lost during acute surgical transitions, risking a preventable embolic stroke. And if a provider writes a vague order like resume all home medications, recognize that as incomplete. Every medication must be individually named, dosed, routed, and timed. Now to high alert medications. Drugs where an error doesn't just cause a mild reaction, it causes a medical emergency or severe injury. First, digoxin. Think of it as a personal trainer for a failing heart. It forces the heart to slow down and contract significantly harder. It has a very narrow therapeutic index, 0.5 to 2.0 nanograms per milliliter. Anything above 2.0 is toxic. Know the sequence of toxicity cues cold. The earliest warning signs are gastrointestinal, anorexia, nausea, vomiting. Neurological and visual changes come next. Blurred vision, yellow-green halos around lights, or white spots. The cardiac signs are the most dangerous. Severe bradycardia, heart blocks, and premature ventricular contractions that can deteriorate into ventricular fibrillation. A lethal emergency? Before administering, auscultate the apical pulse for a full 60 seconds. Never a radial pulse, and never count for just 15 or 30 seconds. Hold the dose and notify the provider if the apical rate is below 60 in an adult, below 70 in a child, or below 90 in an infant. Then check serum potassium. Here's the relationship to understand precisely. Low potassium doesn't mean the digoxin level itself is high, but hypokalemia makes the myocardium hypersensitive to digoxin, letting dangerous toxicity occur even when the blood level looks completely normal. If a toxic patient presents with severe hyperkalemia from the sodium-potassium pump failing, prepare the antidote, digoxin immune fab, immediately. And check kidney function. Digoxin is excreted entirely by the kidneys, so a creatinine above 1.3 means the drug will accumulate to toxic levels. Insulin unlocks the cell's glucose channels. Without it, glucose stays trapped in the blood while cells starve. The exam cares most about the peak. The moment insulin activity is highest is also the moment blood glucose is lowest, and that's your highest risk window for hypoglycemia. Know your onset, peak, and duration cold. Rapid-acting insulins like Lispro and Aspart, onset 15 minutes, peak 30 to 90 minutes, duration 3 to 5 hours. Never give these unless the meal tray is physically in front of the patient. Short-acting regular insulin, onset 30 to 60 minutes, peak 2 to 4 hours, duration 5 to 8 hours. And regular is the only insulin that can run as a continuous IV infusion for DKA. Intermediate-acting NPH, onset 1 to 2 hours, peak 4 to 12 hours, duration 14 hours or more. An evening dose often peaks in the middle of the night, creating a prime window for nocturnal hypoglycemia. Long-acting glargine and detamir, onset 1 to 2 hours, no peak, a steady basal level for 24 hours. Glargine can never be mixed in the same syringe with any other insulin, since mixing alters the pH and causes precipitation. When mixing regular and NPH in one syringe, remember, clear before cloudy. Inject air into the cloudy NPH vial first, then air into the clear regular vial. Then draw up the clear regular insulin, then draw up the cloudy NPH to the total ordered volume. If blood glucose drops below 70, execute the 15-15 rule. 15 grams of simple carbohydrate, wait 15 minutes, recheck, repeat if still low. Once it rises above 70, give a complex carbohydrate with protein, peanut butter and crackers to prevent a secondary crash. Know the Somogyi effect versus the dawn phenomenon. Both present as morning hyperglycemia at 700, but need opposite fixes. Check a 300 blood glucose to tell them apart. A hypoglycemic 0-300 reading means the body crashed overnight and rebounded with counter-regulatory hormones. That's Somogyi, fixed by reducing the evening insulin or adding a bedtime snack. A normal or elevated 0-300 reading means the morning spike is natural growth hormone release. That's dawn phenomenon, fixed by increasing the evening insulin or timing it closer to bedtime. Opioids work by blocking pain signals and slowing the brain's overall activity, which is exactly why sedation is a warning sign, not just a side effect. A brain too relaxed to register pain can become too relaxed to remember to breathe. That's the whole reason respiratory rate gets checked before every single dose. The core drugs are morphine, codeine, methadone, hydromorphone, oxycodone, and hydrocodone. The antagonist is naloxone. Assess respiratory rate first, hold and notify if it's under 12, and establish a baseline pain score. These are Schedule II controlled substances, kept double-locked, with every wasted dose witnessed by a second RN. Push IV opioids slowly, over 2 to 3 minutes. A rapid push raises the risk of immediate respiratory arrest and chest wall rigidity. For patients on a PCA pump, one rule is absolute. Only the patient may press the button, never a family member, a visitor, or a nurse dosing on their behalf, even out of kindness. The patient becoming too sedated to press it is exactly the built-in safeguard that's supposed to stop further dosing. Someone else pressing it for them removes that safeguard entirely and risks fatal oversedation. Contraindications include severe asthma or COPD, paralytic ileus, and head injury, where opioids can mask rising intracranial pressure. The black box warning covers respiratory depression and addiction, and this class is fatal when combined with other CNS depressants like alcohol or benzodiazepines. Expect dry mouth, drowsiness, constipation, which needs a standing stool softener order, pruritus, which is common and not an allergy, nausea, orthostatic hypotension, urinary retention, and pinpoint pupils as a sign of toxicity. Use the sedation scale to guide action. Asleep but easily aroused, or awake and alert, or slightly groggy but easy to wake. All acceptable. Falling asleep mid-conversation is unacceptable. Monitor closely and decrease the dose. Minimal or no response to stimuli is a full emergency. Stop the opioid, call rapid response. Consider naloxone. A handful of the sharpest opioid traps worth knowing. Never set aside a partial dose for later. Any unused portion of a vial has to be wasted immediately with a second nurse witness, or it's a diversion risk. Meperidine in renal failure is a real trap. Its metabolite causes seizures, so watch for tremors and prefer a different opioid. 2 milligrams of morphine and 2 milligrams of hydromorphone are not equivalent. Hydromorphone is 5 to 7 times stronger, so verify the math every time. And after naloxone reverses an overdose, don't assume the crisis has passed just because the patient is awake. Naloxone's half-life is shorter than most opioids, so monitor for a full 2 hours to prevent rebound apnea. If you want the complete trap library for this section, PCA agitation as the first sign of respiratory compromise, the epidural hematoma leg weakness trap, the OSA plus opioid combination, and a full who do you see first, with all 8 scenarios worked out. That's all in the guide on Etsy, broken down exactly like everything else you've heard so far. For IV heparin, the mechanism is immediate catalyst activation of antithrombin 3, halting the clotting cascade in acute crises like pulmonary embolism or MI. The therapeutic goal for continuous IV heparin is an APTT between 1.5 and 2.5 times control, typically 60 to 80 seconds. If it climbs above 80 to 100 seconds, stop the infusion and prepare the reversal agent, protamine sulfate. Always monitor the platelet count on heparin. If it drops by 50% or falls below 150,000 within 4 to 10 days of starting therapy, suspect heparin-induced thrombocytopenia, HIT. Stop all heparin sources immediately, mark it as an allergy, and anticipate switching to an IV direct thrombin inhibitor like argatroban. For IV potassium and magnesium, the rules are non-negotiable. Potassium chloride is a severe vesicant and must never go in as an IV push. Pushing it stops the heart in diastole, a lethal injection. It must always be diluted and run through an electronic infusion pump with a maximum peripheral rate of 10 milliequivalents per hour. Magnesium sulfate is your primary membrane stabilizer, indicated for torsades de pointe, preeclampsia seizure prophylaxis, and acute severe hypomagnesemia. It's excreted entirely by the kidneys, so urine output below 30 milliliters an hour means it's accumulating toward toxicity. Assess using the toxicity ladder. The earliest cue is the loss of deep tendon reflexes. If the patellar reflex is absent, stop the infusion immediately, notify the provider, and prepare calcium gluconate. Don't wait for respiratory depression or cardiac arrest to intervene. The DEA and the hospital board care about exactly one thing. Every milligram has to be accounted for. If 5 milligrams leaves the cabinet, 5 milligrams has to enter either the patient or the waste bin. Anything else is a discrepancy. Treat it as diversion until proven otherwise. The formula: amount pulled equals amount given plus amount wasted. Know the schedule cheat sheet. Schedule 1 has no legal medical use, heroin, LSD, ecstasy. Schedule 2 carries high abuse potential with no refills, morphine, fentanyl, Adderall, oxycodone. Schedule 3 through 5 carries lower abuse potential with limited refills, codeine combinations, benzodiazepines. The wasting protocol tests the why, when, and where. Who? 2 licensed nurses, RN and RN or RN and LPN, a CNA or pharmacy tech cannot witness. When? Immediately. Never carried in a pocket. Where? A chemical digester, never the sharps container or regular trash. The steps run in order. Pull it from the dispensing cabinet, verify the vial and volume with the second nurse, witness the liquid actually enter the waste bin, and both nurses sign the record at the same time. A discrepancy exists the moment the physical count doesn't match the screen. The priority action is to stop. Don't pull your own medication. Don't try to adjust the count yourself. Notify the charge nurse or supervisor immediately, and let them audit the last user before anyone touches the bin. One sharp trap worth knowing: never sign a witness log based on trust alone. You can only witness a waste if you physically saw the fluid enter the bin. If you didn't see it, it didn't happen. And signing anyway is falsifying a legal record. Learn to recognize diversion red flags in a coworker, since this shows up in Next Gen case studies. A patient reporting pain only when one specific nurse is on duty, a nurse asking for a co-signature after the syringe is already empty, or someone who consistently volunteers to give opioids for other nurses' patients. Never confront a coworker you suspect is diverting. Report it to the supervisor instead. The full set of controlled substance scenarios: the mid-waste code blue trap, the fentanyl patch disposal rule, the broken vial reporting requirement, the PCA dual verification specifics, is laid out the same way in the full guide on Etsy. Links below if you want it open, next to you while you study. Prioritization check. 4 scenarios, 1 nurse. Pause the video right now, read the list on the screen, and lock in who you would see first. If you chose the patient on a PCA pump who is suddenly agitated, restless, and trying to pull at their IV lines, you saved a life. Restlessness is the brain's first cry for oxygen. If you wait for them to get sleepy, you've missed the window for severe respiratory depression. Here is the breakdown for the rest of the traps on your screen. A patient with an epidural opioid infusion who reports new onset leg weakness or inability to wiggle their toes. This is a sign of an epidural hematoma. If not treated, the pressure causes permanent paralysis. A patient with renal failure on morphine who develops new onset hallucinations and muscle jerking. The kidneys aren't clearing the active metabolites, leading to severe neurotoxicity. And a nurse who places a pre-filled fentanyl syringe in their scrub pocket to attend to a cardiac arrest in the next room. This is a legal violation and diversion risk. The syringe must be handed to the charge nurse to lock up. ABCs override the waste, but pocketing a narcotic is never allowed. Module 2, Pharmacokinetics, Dynamics, and Autonomic Nervous System. Before any specific drug class makes sense, we need to understand the life cycle of a medication, what the body does to a drug, what the drug does to the body, and one master rule that predicts almost every autonomic drug on this exam. We'll move fast. This module is short by design. The single highest yield concept here is the first pass effect. Oral drugs travel through the portal vein straight to the liver before ever reaching general circulation. and the liver metabolizes a big chunk of the dose before it counts. That's why 30 milligrams of oral morphine is roughly equivalent to just 4 milligrams IV. If you ever see an order for 30 milligrams of IV morphine, that's not a typo to gloss over. Without the liver buffering it, that's severe respiratory depression waiting to happen. And in a patient with liver failure or cirrhosis, any drug that relies heavily on first-pass metabolism will accumulate to toxic levels because the buffer itself is broken. One administration rule that saves lives constantly: never crush an enteric-coated or extended-release medication. Crushing destroys the coating designed to control where and how fast the drug releases, and the result is dose dumping, the entire extended-release dose hitting the bloodstream at once. Watch for one more absorption trap at the gut level: the P-glycoprotein efflux pump. Think of it as a bouncer in the intestinal wall that shoves certain drugs back out before they're ever absorbed. Verapamil disables that pump, and when it does, other drugs that rely on it, like digoxin, get absorbed far more completely than intended, pushing levels toward toxicity. Protein binding matters for exactly two drugs you'll see repeatedly: warfarin and phenytoin. Only the free, unbound portion of a drug is active. In a patient with low protein, elderly, malnourished, less drug gets bound, so more stays free and active, and toxicity risk climbs even without a dose change. Volume of distribution tells you where a drug actually hides, and it directly predicts whether dialysis will work in an overdose. A drug with a high VD, highly lipophilic, sequestered deep in fat and tissue, is essentially invisible to hemodialysis because the machine only cleans the blood and the drug isn't there anymore. Digoxin and TCA overdoses fall into this category. You cannot wash them out this way. A drug with a low VD stays in the blood, where dialysis can actually reach it. Lithium and gentamicin overdoses respond well to hemodialysis for exactly this reason. Know these two enzyme interactions cold. Grapefruit juice shuts down CYP3A4 metabolism in the gut. Combine it with a statin, and nearly the full dose hits the bloodstream, driving real rhabdomyolysis risk. St. John's wort does the opposite. It speeds up drug breakdown, which is why warfarin or oral contraceptives taken alongside it quietly stop working. Excretion happens primarily through the kidneys, and you can manipulate it. Sodium bicarbonate alkalinizes the urine, which traps a weak acid like aspirin in its ionized form in the tubular lumen and forces it out with the urine. This is ion trapping, and it's a real overdose management tool, not just theory. And one administration trap worth knowing: tetracyclines and fluoroquinolones bind to calcium, magnesium, and iron. Dairy, antacids, and iron supplements all block their absorption, so these need to be spaced at least 2 hours apart from any of those. Two concepts, two traps. First, receptors change with chronic exposure. Chronic exposure to an agonist causes downregulation. The cell hides receptors, and the patient needs more drug for the same effect. That's tolerance. Chronic exposure to an antagonist, like a beta blocker, causes upregulation. The cell builds extra receptors to compensate for the block. Stop that beta blocker abruptly, and the sudden removal of the block leaves a surge of catecholamines hitting an army of newly sensitized receptors. That's a rebound hypertensive crisis, or MI. Beta blockers are never stopped cold. Second, efficacy is not potency. Efficacy is the maximum effect a drug can produce. Potency is how much drug it takes to get there. Hydromorphone is significantly more potent than morphine, milligram for milligram. Swapping 2 milligrams of morphine for 2 milligrams of hydromorphone as if they were interchangeable is a real overdose risk, not a rounding error. One more number worth knowing: therapeutic index, the safety margin between a drug's effective dose and its toxic dose. A narrow therapeutic index means a small change in dose or blood level can swing a patient from therapeutic to toxic. Digoxin, lithium, warfarin, phenytoin, vancomycin, and theophylline all live in this category, which is exactly why they all require blood level monitoring. Picture Jack walking peacefully down the street. A dog suddenly jumps out and barks at him. His sympathetic nervous system fires instantly. That's fight or flight, driven by norepinephrine and epinephrine. Here's the one rule that lets you predict almost every adrenergic drug on the exam from that single moment without memorizing each drug individually. Tissues useful in that crisis get stimulated through alpha-1 receptors. Vessels constrict, sphincters close, glands activate. Tissues not useful in a crisis get relaxed, through beta-2 receptors. Airways open, vessels in those beds dilate, glands cut back. 3 genuine exceptions: the heart, the kidney's juxtaglomerular cells, and the pineal gland are all stimulated in a crisis, but through beta-1, not alpha-1. That kidney exception matters more than it looks. Juxtaglomerular cells release renin when stimulated. Renin kicks off the whole angiotensin cascade, ending in vasoconstriction and rising blood pressure. That's exactly the pathway ACE inhibitors interrupt downstream, which is why they lower blood pressure. A few organ-specific effects map directly to real drugs. In the eye, alpha-1 stimulation dilates the pupil. That's why phenylephrine is used before an eye exam. In the bladder, alpha-1 contracts the internal sphincter to hold urine, which is why tamsulosin, an alpha-1 blocker, relaxes the bladder neck for BPH. But it also explains the urinary incontinence that can follow. The detrusor muscle itself relaxes under beta-3, which is why mirabegron, a beta-3 agonist, treats overactive bladder from the opposite direction. And the uterus flips depending on pregnancy. Alpha-1 contracts it normally, but in pregnancy, beta-2 dominates and keeps it relaxed, which is exactly why terbutaline, a beta-2 agonist, is used to stop preterm labor. Everything downstream follows from this master rule. A pure alpha-1 agonist like phenylephrine causes vasoconstriction and raised blood pressure, which then triggers the vagus nerve to slow the heart down in response, a reflex bradycardia. Dopamine's effects are entirely dose-dependent, moving through 3 distinct zones as the dose climbs. Low dose stimulates D1 receptors in the kidney to boost renal perfusion. Moderate dose stimulates beta-1 in the heart to boost cardiac output. High dose shifts to alpha-1 and causes systemic vasoconstriction. Blocking alpha-1 with a drug like prazosin dilates vessels, and the very first dose can drop blood pressure hard enough to cause syncope, which is why that first dose is always taken at bedtime. Alpha blockers are also contraindicated in patients with reduced coronary perfusion. The compensatory reflex tachycardia that follows the blood pressure drop can push a compromised heart straight into an MI. And prazosin alone is never used as monotherapy in heart failure because it causes sodium and water retention on its own. Blocking both beta-1 and beta-2 with a non-selective beta blocker like propranolol is contraindicated in asthma or COPD because blocking beta-2 prevents the airway from relaxing and can trigger bronchospasm. And in a diabetic patient, these drugs mask the sympathetic warning signs of hypoglycemia, hiding the racing heart and the tremor, leaving sweating as the only warning sign that still gets through. If a beta blocker overdose does happen, heart rate in the 30s, blood pressure collapsing, atropine won't reliably fix it because the receptors themselves are still blocked. The real antidote is glucagon, which raises heart rate and contractility through its own separate G protein pathway, completely bypassing the blockade. Last piece, the parasympathetic side and a genuine emergency. In cholinergic crisis, organophosphate poisoning for example, you'll see dumbbells, diarrhea, urination, meiosis, bradycardia, bronchospasm, emesis, lacrimation, salivation. The immediate priority is IV atropine, which blocks those muscarinic receptors and dries up the drowning respiratory secretions, followed by pralidoxime. 2 traps worth knowing here. Don't confuse cholinergic toxicity with anticholinergic toxicity. Anticholinergic overdose looks almost opposite. A high fever, dry flushed skin, a racing heart, absent bowel sounds. Standard antipyretics won't touch that fever because the real problem is anhydrosis. The patient physically cannot sweat to cool down, so it's managed with cooling measures, not Tylenol. And genuinely high stakes. A myasthenia gravis patient on pyridostigmine who develops increasing weakness could be in one of 2 opposite crises, and treating the wrong one is dangerous. Myasthenic crisis means not enough acetylcholine. The disease is undertreated, and more drug is usually needed. Cholinergic crisis means too much acetylcholine from an overdose of the drug itself, and it comes with that dumbbells picture. Excess secretions, sweating, meiosis. If those signs are present, hold the dose. If they're absent and it's just progressive weakness with dry mucous membranes, that points toward myasthenic crisis instead. Prioritization check. 4 patients, 1 nurse. Pause the video right now, read the list on the screen, and lock in who you would see first. If you chose the patient on a labetalol infusion who has collapsed and stopped responding to voice, you saved a life. You must stop the infusion immediately and prepare IV glucagon. Atropine has limited effect against a fully blocked receptor. Here are the rationales for the rest of the patients on your screen. A farm worker with pinpoint pupils, labored breathing, audible secretions, and bradycardia after a pesticide spill. Cholinergic crisis. IV atropine first, then pralidoxime. A myasthenia gravis patient on pyridostigmine with 90 minutes of worsening difficulty swallowing and speaking. No secretions, no meiosis, no diaphoresis, saying I cannot breathe properly. The absence of dumbbells points to myasthenic crisis, not overdose. This patient needs airway support and likely more drug, not less. And a patient who just self-discontinued their beta blocker after months of therapy and now presents with a blood pressure of 210/120 and chest pain. Rebound catecholamine surge hitting upregulated receptors, heading toward MI or hypertensive crisis. Module 3, Cardiac Pharmacology and the Hemodynamic Core. Stop thinking of heart drugs and kidney drugs as two separate topics. The NCLEX tests them as one closed loop. Think like a plumber. There are 4 parts to this system: the pump, the pipes, the fluid, and the drain. The pump is the heart. Slow it down with metoprolol or diltiazem. Strengthen it with digoxin or dobutamine. The pipes are the blood vessels. Clamp them shut with norepinephrine. Open them up with nitroglycerin or lisinopril. The fluid is blood volume. Fill the tank with normal saline or albumin. And the drain is the kidneys. Empty the tank with furosemide. Here's your bedside equation. Blood pressure equals speed plus squeeze times the tightness of the pipes times volume. When a patient is crashing into shock, find the one broken variable and fix only that one. Picture a septic patient. Blood pressure 70/40, heart rate 125, skin warm and flushed. Volume's fine, the pump's compensating. The pipes are the problem. Sepsis blows them wide open. Fix, clamp them with norepinephrine. Now a heart failure patient in cardiogenic shock. Blood pressure 80/50, crackles, heavy pitting edema. The tank is already overloaded and the pipes are clamped tight to compensate. The pump itself is the problem. It's too weak to move the volume it has. Fix, strengthen the squeeze with dobutamine, never bolus fluid here, and a post-op patient in hemorrhagic shock. Blood pressure 75/45, skin cold, pale, and clammy. The pipes are already clamped as tight as they'll go, trying to protect the core. The tank itself is empty. Fix, fill it with normal saline. One tonicity trap worth knowing while we're on fluids. Isotonic fluids like normal saline are the standard choice for volume replacement, since they don't shift fluid into or out of the cells. Hypotonic fluids like 0.45%, saline, or D5W work the opposite way. And in a patient with a head injury or rising intracranial pressure, they are contraindicated because they shift water into already swollen brain cells and make the pressure worse. For mean arterial pressure, the math is systolic plus 2 times diastolic divided by 3. We double the diastolic because the heart spends twice as long resting and filling as it does squeezing. Below 65, it's an emergency. The organs are starving for blood. Let's talk diuretics. Water is lazy. It follows sodium. These drugs dump sodium into the urine and water follows it right out. The very first sign of a potassium problem is muscle cramps or leg weakness. Check that level immediately. Loop diuretics waste calcium. Thiazides save it. Never schedule a diuretic after 5 p.m. That's a fall risk from nighttime bathroom trips. And don't trust intake and output. Daily weights are your gold standard. Here's the push rate rule. Furosemide by IV push, never faster than 20 milligrams a minute, or you risk permanent hearing damage. And here's a trap worth remembering. Loop diuretics waste potassium. Low potassium makes the heart hypersensitive to digoxin. So a patient can develop lethal digoxin toxicity even when their digoxin level looks completely normal. And if your patient is on spironolactone, warn them off salt substitutes. Those are pure potassium chloride. And combined with a potassium-sparing diuretic, that's a fast track to lethal hyperkalemia. Next, ACE inhibitors and ARBs. These block angiotensin II, so the vessels relax, and aldosterone drops. Remember the 3 ACE side effects: angioedema, cough, and elevated potassium. ARBs skip the cough because they block the pathway further downstream. Hold these drugs if systolic blood pressure is under 90 or if potassium is over 5. They're category X, so confirm a negative pregnancy test before that first dose. And watch for first dose hypotension. Teach patients to take that very first pill at bedtime. One more trap. Never pair an ACE inhibitor with a potassium-sparing diuretic without close monitoring. Both drugs tell the kidneys to hoard potassium. Calcium channel blockers relax the vessel walls. With the depine drugs, expect peripheral edema. Swollen ankles are normal here, so elevate the legs, don't reach for a diuretic. Diltiazem and verapamil act more on the heart itself. Hold if heart rate is under 60. And grapefruit juice is contraindicated across this whole class. Nitrates dilate the veins to reduce preload and the coronary arteries to bring oxygen to a starving heart. A pounding headache is expected. Treat it with Tylenol. Don't hold the dose. Follow the 911 rule. One tablet under the tongue, and if the pain isn't gone in 5 minutes, call 911. Here's a trap that can kill a patient fast. Nitroglycerin combined with sildenafil or tadalafil causes a fatal drop in blood pressure. Always ask about erectile dysfunction medications before giving nitrates. And with hydralazine, watch for drug-induced lupus. A butterfly-shaped facial rash is your clue. Vasopressors clamp the pipes shut to raise blood pressure in shock. Norepinephrine is first line for sepsis. Epinephrine is your rescue drug for cardiac arrest and anaphylaxis. Because these drugs clamp so hard, watch the extremities and the urine output. Perfusion can drop even while the numbers on the monitor look better. If one of these infusions extravasates, stop it immediately, but leave the IV in place. Aspirate what you can, then inject phentolamine right into the site. Pulling the line out here can cost the patient a limb. Beta blockers and drugs like diltiazem and verapamil put the brakes on the pump. Hold for a heart rate under 60. Non-selective beta blockers are contraindicated in asthma and COPD. They can trigger a dangerous bronchospasm, and they mask the symptoms of hypoglycemia in diabetics. Sweating is the only warning sign that gets through. Never stop a beta blocker abruptly. That sets off a rebound hypertensive crisis or even a heart attack. Digoxin slows the heart rate while making each beat stronger. ICU drugs like dobutamine and milrinone force the heart to squeeze harder without slowing it down. Always check the apical pulse for 1 full minute before giving digoxin. Hold if the heart rate is under 60 in an adult, under 70 in a child, or under 90 in an infant. Remember, low potassium causes digoxin toxicity even at a normal drug level. And with milrinone, watch the blood pressure closely. It vasodilates the pipes at the same time it strengthens the squeeze, so pressure can crash. A quick rundown here. Adenosine gets pushed fast, 1 to 2 seconds, into an antecubital vein, followed immediately by a rapid saline flush. Amiodarone is toxic to the lungs, thyroid, and eyes, and can turn the skin a blue-gray color over time. Lidocaine toxicity shows up as slurred speech and seizures. Atropine is contraindicated in acute glaucoma, and it won't work on a third-degree heart block. And magnesium sulfate is your drug of choice for torsades de pointe. For an acute MI, the acronym is MONAB, but the NGN tests the actual order of operations: oxygen, aspirin, nitroglycerin, then morphine. Give oxygen only if the saturation is below 90%, or the patient is in obvious respiratory distress. Have the patient chew the aspirin, 324 milligrams, for faster absorption. Give sublingual nitroglycerin every 5 minutes, up to 3 doses, and hold if systolic pressure drops below 90. Morphine is a last resort, and beta blockers get started within 24 hours, unless the patient is bradycardic or in heart block. One critical trap: a right-sided MI is preload dependent. Giving nitrates or morphine here will crash the blood pressure. These patients need fluids, not vasodilators. For heart failure, remember, left-sided failure backs up into the lungs, crackles, frothy sputum. Right-sided failure backs up into the rest of the body, JVD, edema, ascites. A BNP over 400 signals a crisis. For pulmonary edema, follow unload, upright positioning, nitroglycerin, Lasix push slowly, oxygen, and morphine. 2 traps to know cold. Never give a fluid bolus in cardiogenic shock. It will trigger flash pulmonary edema. And hold beta blockers during an acute exacerbation. At discharge, teach patients the FACES of worsening failure, a sodium limit under 2 grams a day, and to report a 3-pound weight gain in 2 days. NSAIDs are off the table entirely. Heparin and Lovenox work fast. Warfarin takes days to build up, so it needs bridge therapy until the INR reaches 2 or higher. Watch for HIT. If platelets drop by 50%, or fall below 150,000, stop the heparin immediately. DOACs don't need routine monitoring, but the bleeding risk is real, and each one has its own specific reversal agent. Andexanet alpha, Zabans, like rivaroxaban and apixaban, idarucizumab for dabigatran. Antiplatelets like aspirin and clopidogrel need to be held 5 to 7 days before surgery, and TPA has a strict window, 3 to 4.5 hours, and is contraindicated above a blood pressure of 185/110. If the patient reports the worst headache of their life during a TPA infusion, stop it immediately. Last group, statins. They're hepatotoxic, and they carry a real risk of rhabdomyolysis. Muscle aches paired with dark urine means hold the drug and draw a CK level. Grapefruit juice is contraindicated, and they're category X in pregnancy. With niacin, expect flushing. It's normal, and pretreating with aspirin can blunt it. Prioritization check. Pause the video right now, read the list on the screen, and lock in who you would see first. If you chose the patient on lisinopril whose tongue feels thick, you saved a life. That is angioedema. They are seconds away from completely losing their airway. The patient on TPA reporting the worst headache of their life is a close second. That is a brain bleed, but the airway always wins. Next, Module 4, Respiratory and Antibiotic Systems. For the NCLEX, we treat the airway strictly from the top down. A closed throat kills faster than a tight lung. There are 4 crisis levels to know. Level 1 is severe upper airway edema, like anaphylaxis. Level 2 is acute bronchospasm, like an asthma attack. Level 3 is chronic mucosal inflammation. Level 4 is a mucus plug completely blocking the airway, like in cystic fibrosis or pneumonia. Every drug in this module exists to fix one of those 4 levels. Level 1 is a full system reset, and epinephrine is that reset. It hits alpha 1, beta 1, and beta 2 receptors all at once, reversing the shock, boosting cardiac output, and forcing the airway back open. Inject it into the vastus lateralis the moment you see stridor, lip or tongue swelling, or a crashing blood pressure. Tachycardia and a feeling of impending doom are expected. Never withhold the dose because the heart rate looks alarming. Here's the trap that catches almost everyone. The route of epinephrine is not interchangeable, and it tells you exactly what's happening clinically. Epinephrine is for a conscious, breathing patient in anaphylaxis. It's a nurse-initiated standing order, so you don't wait for a provider call. IV epinephrine is strictly for a code blue, pulseless cardiac arrest, given by the code team under ACLS protocol, 1 mg every 3 to 5 minutes. If a patient in anaphylaxis has a blood pressure of 60/40 and is unresponsive, the tempting answer is prepare IV epinephrine. That's wrong. IM comes first, always. IV is only a last resort once IM has failed and a provider has already established IV access. One more distinguishing trap. Albuterol fixes a wheeze, not a stridor. If the sound is high-pitched and coming from the throat, that's upper airway swelling. Albuterol will do nothing. That patient needs IM epinephrine immediately. And if a patient develops hives and labored breathing while receiving IV antibiotics like vancomycin or penicillin, the sequence is absolute. Stop the infusion first, then give epinephrine. If symptoms haven't improved 5 to 15 minutes after the first IM dose, give a second one. Epinephrine's half-life is short. And any patient who used an EpiPen in the community still needs the emergency department, because a delayed biphasic reaction can strike hours later. For levels 2 and 3, we widen the airway first with the BAM protocol. Beta-2 agonists, anticholinergics, and methylxanthines. Albuterol is your instant rescue drug. Salmeterol is maintenance only. Giving it during an acute attack is a fatal timing error, since it can take up to 20 minutes to even start working. Expected beta-2 side effects are the 3 T's: tachycardia, tremors, and trouble sleeping. Watch potassium too. High doses can drop it below 3.5. Anticholinergics, like ipratropium, dry the whole system out. They're contraindicated in narrow angle glaucoma and BPH. The drying effect will spike eye pressure or lock up the bladder. Methylxanthines, like theophylline, have a brutally narrow window, 10 to 20 micrograms per milliliter. Toxicity looks like a caffeine overdose. Seizures, tachycardia, fatal dysrhythmias. Cut caffeine entirely. And watch 2 specific interactions, cimetidine and ciprofloxacin, both block the liver's ability to clear theophylline, sending levels into the toxic zone. Quitting smoking has the same effect, since smoking speeds up theophylline metabolism. A patient who quits cold turkey on an unchanged dose can suddenly become toxic. Always open the pipes before you fight the fire. Bronchodilator first, wait 5 minutes, then the steroid. Otherwise, the steroid can't reach deep lung tissue. Anti-inflammatories fall into 3 buckets: steroids, leukotriene modifiers, and mast cell stabilizers. Inhaled steroids carry the 5 S's: hyperglycemia, softened bones from osteoporosis, immunosuppression, sadness or depression, and salt and water retention causing weight gain. Locally, they cause oral thrush, rinse and spit after every dose, and clean the spacer weekly. Leukotriene modifiers like montelukast carry an FDA black box warning for severe neuropsychiatric events: agitation, aggression, depression, suicidal ideation. If a child on montelukast suddenly develops aggression or nightmares, that is not poor sleep hygiene. Stop the drug and notify the provider immediately. Mast cell stabilizers like cromolyn are strictly preventive, taken 30 minutes before exercise or known allergen exposure. They do nothing for an active attack. None of these 3, steroids, leukotriene modifiers, or mast cell stabilizers, are rescue drugs. They're slow. Never reach for them during an acute crisis. Here's the highest acuity trap in this entire section. An asthmatic patient on continuous albuterol whose loud wheezing suddenly goes quiet while they're still visibly struggling is not improving. That's silent chest. The airway has completely clamped shut and 0 air is moving. Call the rapid response team and prepare for immediate intubation. A few more respiratory drugs you need cold. Expectorants like guaifenesin thin secretions by pulling water into the airway, but they're useless without 2 to 3 liters of fluid a day to actually thin the mucus. Mucolytics like acetylcysteine chemically break down thick mucus. The trade-off is that it can trigger a severe bronchospasm, so always have albuterol at the bedside. It also has a normal, expected rotten egg smell. That's not a reason to hold it. And remember acetylcysteine's other job. It's the antidote for acetaminophen toxicity. Antitussives like codeine suppress the cough center. Never give one to a patient with a wet, productive cough, like pneumonia. Suppressing that cough traps fluid and bacteria in the lungs and can lead to sepsis. Decongestants like oxymetazoline constrict nasal vessels to open the passages, but they're strictly limited to 3 days of use. Go longer, and you get rebound congestion, where the nasal passages swell shut worse than before. One more distinguishing assessment. Guaifenesin treats thick, rust-colored or green-yellow sputum, which points to pneumonia. Pink, frothy sputum is a different problem entirely. That's pulmonary edema, and it needs diuretics, not an expectorant. Now the anti-infective army. Always draw blood and sputum cultures before the very first dose of any antibiotic. Treating first pollutes the sample, and you'll never get an accurate result. Penicillins, cephalosporins, carbapenems, and vancomycin all attack the bacterial cell wall. Without it, water rushes in and the bacteria physically bursts. Penicillins and cephalosporins share a beta-lactam ring, creating a 10% cross-allergy rate. If a patient reports true anaphylaxis to penicillin, throat closing, not just a rash, hold the cephalosporin too. After a first IV penicillin dose, stay with the patient for 15 to 30 minutes to watch for rapid anaphylaxis. Penicillin G potassium carries a real potassium load. Give it to a patient in renal failure, and you can trigger lethal hyperkalemia. Carbapenems carry a real seizure risk, especially in patients with renal impairment or a seizure history. And here's a trap worth memorizing. Carbapenems rapidly crash valproic acid levels. A seizure patient stabilized on valproic acid who receives a dose of meropenem and starts twitching isn't just anxious, their seizure threshold is collapsing in real time. That's an emergency. Vancomycin is both nephrotoxic and ototoxic. Infuse it over 60 to 90 minutes minimum, or you risk red man syndrome, flushing of the face, neck, and chest from histamine release, not a true allergy. Slow the infusion if it happens. It's rate-related, not anaphylaxis. For trough levels, never draw from the arm the vancomycin is infusing into, and never draw a trough after the first dose. Steady state isn't reached until right before the 3rd or 4th dose. A trough over 20 with a rising creatinine means hold the dose and notify the provider immediately. One more high-yield trap: never mix ceftriaxone with a calcium-containing fluid like lactated ringers or TPN. It forms a lethal precipitate that destroys the lungs and kidneys. Use a dedicated line or flush thoroughly with saline first. These bind the ribosome and stop bacteria from building the proteins they need to survive. Tetracyclines cause photosensitivity and permanently stain developing teeth. Category X, avoid in pregnancy and young children. Take on an empty stomach, calcium, iron, and antacids neutralize the drug, so stagger dosing by 1 to 2 hours. Macrolides like azithromycin prolong the QT interval, a real risk for fatal torsades de pointes, especially combined with another QT prolonging drug like amiodarone. Check the EKG. Aminoglycosides like gentamicin and tobramycin are toxic to the ears and kidneys. New tinnitus or dizziness on one of these drugs is not orthostatic hypotension. It's the first sign of permanent cranial nerve damage. Hold the drug and notify the provider. Peak levels are drawn 30 minutes after the infusion ends, never while it's still running. Clindamycin is the single most common pharmacological cause of C. diff, and linezolid acts like a weak MAOI. Combine it with an SSRI, and you risk serotonin syndrome, so avoid high tyramine foods too. Fluoroquinolones like ciprofloxacin carry a black box warning for Achilles tendon rupture, a sudden, sharp, tearing pain in the calf or heel in an elderly patient is not a strain. Hold the drug and start bed rest immediately. They're also absolutely contraindicated in myasthenia gravis, where they can trigger lethal respiratory failure. Metronidazole treats GI anaerobes and C. diff, but mixed with alcohol, it causes a violent disulfiram-like reaction. No alcohol during treatment or for 3 days after. It also causes a metallic taste and dark urine, both completely expected, not a reason to hold the drug or panic. Nitrofurantoin treats UTIs, but carries a real risk of pulmonary fibrosis. A new cough, chills, or shortness of breath means stop the drug immediately. Rifampin, which we'll also see in TB treatment, turns every body fluid, tears, sweat, urine, red-orange. Completely expected. Don't hold the drug, just switch contact lens wearers to glasses. Sulfonamides starve bacteria of folic acid. Watch for crystalluria in a dehydrated patient. Push 2 to 3 liters of fluid daily. The real danger is Stevens-Johnson syndrome, a red-purple rash involving the mucous membranes, like the lips or inside the mouth, is not a mild sensitivity. Stop the drug immediately and isolate the patient. Also watch for sulfa cross-sensitivity. Patients allergic to sulfonamides can react to sulfonylurias like glyburide and to loop diuretics like furosemide, so question those orders too. Amphotericin B is nicknamed amphoterrible for good reason, severe infusion reactions and heavy nephrotoxicity. Premedicate 30 to 60 minutes ahead with acetaminophen and diphenhydramine. If the patient develops violent shivering or rigors, warm blankets aren't enough. You need IV meperidine or dantrolene to stop the muscle spasms. Watch potassium and creatinine closely throughout. Azoles like fluconazole are hepatotoxic and prolong the QT interval. Dark urine, clay-colored stools, or yellowing sclera means acute liver toxicity. Hold the drug. Next, antivirals. These don't cure a virus, they suppress it. Acyclovir crystallizes in the renal tubules. Aggressive IV hydration during and after the infusion is mandatory to prevent kidney injury. If the patient reports burning at the IV site, stop and check for infiltration. It's caustic to veins. Ganciclovir causes severe bone marrow suppression. A sudden fever, sore throat, or unexplained bruising means hold the drug and check the CBC. Oseltamivir for influenza is only effective within 48 hours of symptom onset. After that, it's essentially useless. And a teaching point patients often miss. Acyclovir and valacyclovir are not a cure. Patients must abstain from sexual contact while active lesions are present, medication or not. TB treatment runs 6 to 12 months on 4 drugs at once: rifampin, isoniazid, pyrazinamide, and ethambutol. Directly observed. Therapy is standard. A nurse physically watches the patient swallow the pills because non-compliance here is a public health emergency. All 3 of rifampin, isoniazid, and pyrazinamide are hepatotoxic. 0 alcohol, no exceptions. Isoniazid depletes vitamin B6, causing peripheral neuropathy. If a patient reports tingling in month 2, you don't stop the drug, you add B6. Ethambutol is the one true stop immediately drug in this combination. It causes optic neuritis and blurry vision or loss of red-green color vision means hold the drug before it becomes permanent blindness. And rifampin has one more high-yield trap. It destroys the effectiveness of oral contraceptives. Patients need a non-hormonal backup method for the full course. A patient is only cleared from airborne isolation after 3 consecutive negative early morning sputum cultures, not just feeling better. Every trap you just heard, the root logic, the drug interactions, the exact thresholds, is broken down the same way, drug class by drug class, in the full guide on Etsy. Links below if you want it open next to you while you study. Prioritization check. 7 patients, 1 nurse. Pause the video right now, read the list on the screen, and log in who you would see first. If you chose the patient on their first dose of IV ceftriaxone, reporting a thick tongue and inspiratory stridor, you saved a life. Rapid onset anaphylaxis. Their airway is closing in minutes without IM epinephrine. Here is the breakdown for the rest of the patients on the screen. Next, a patient on azithromycin who's also taking amiodarone, now showing a prolonged QT and frequent PVCs. That's a fatal torsades de points forming in real time. Then, a seizure patient on valproic acid who just received meropenem and is now twitching. Their seizure threshold is crashing towards status epilepticus. Then, a patient on trimethoprim sulfamethoxazole with a new fever, sore throat, and blistering lesions in the mouth. That's Stevens-Johnson syndrome, and the drug must stop immediately. Then, a patient on vancomycin with a trough of 28 and urine output down to 15 milliliters an hour. Acute renal failure in progress. Hold the dose now. Then, a TB patient on ethambutol reporting blurry vision and losing red-green color discrimination. Hold the drug before that nerve damage becomes permanent. And last, stable, not urgent, a patient on metronidazole panicking over dark urine and a metallic taste. Both are completely expected. Reassure, don't intervene. Module 5, Endocrine and GI Pharmacology. Think of the endocrine system as a set of dials. A blood sugar dial, a metabolic speed dial, a stress dial. Think of the GI tract as a conveyor belt you can speed up, slow down, or coat. Every drug in this module turns one of those dials or touches that belt. Type 2 diabetes is a dual problem. The tissues are resistant and the pancreas is worn out. These drugs attack from 4 different angles. In the liver and the tissues, metformin and the TZDs cut the liver's glucose output and make muscle more sensitive to the insulin it already has. In the pancreas, sulfonylureas and meglitinides squeeze the beta cells for whatever insulin is left. In the kidneys, SGLT2 inhibitors block glucose reabsorption, dumping it straight into the urine. And in the gut, GLP-1 agonists, along with a carbose, slow gastric emptying, and blunt carb breakdown. TZDs cause real fluid retention and are contraindicated in heart failure. They're also hepatotoxic and carry a bladder cancer link, so dark urine or painless blood in the urine is worth reporting immediately. GLP-1 agonists can trigger pancreatitis. Sudden upper left abdominal pain radiating to the back is the tell. And sulfonylureas and meglitinides are the only oral classes with a direct hypoglycemia risk, since they force insulin release regardless of what's actually happening with food intake. Timing matters a lot here. Metformin goes with meals. Meglitinides, 15 to 30 minutes before eating. Skip the meal, skip the pill. Acarbose with the very first bite of food. And here's the NPO law. 0 carbs coming in means you hold sulfonylureas and meglitinides, or you're setting up a hypoglycemic coma on the operating table. A handful of traps worth knowing cold. Hold metformin 48 hours before and after contrast dye. Combining them risks lactic acidosis. Glyburide is dangerous in the elderly under the Beers criteria. Its longer half-life means delayed, severe hypoglycemia that can catch a whole shift off guard. If a patient on a carbose goes hypoglycemic, juice and candy won't work. The drug is actively blocking complex carb breakdown, so you need pure dextrose instead. GLP-1 agonists are contraindicated in severe gastroparesis. Watch for euglycemic DKA on SGLT2 inhibitors. The blood sugar can look completely normal while the patient is in DKA, so you have to check urine ketones, or you'll miss it entirely. And long-term metformin use blocks B12 absorption, new numbness, and tingling in a diabetic patient isn't automatically diabetic neuropathy. Check the B12 first. For evaluation, you're looking for a fasting glucose between 70 and 110, an HbA1c under 7%, and no signs of hypovolemia or acute abdominal pain. On the thyroid axis, levothyroxine simply replaces missing T4. Methimazole, PTU, and radioactive iodine go the other direction, blocking hormone synthesis or destroying thyroid tissue outright to slow down an overactive gland. That suppression can spill over into the bone marrow. On the adrenal axis, prednisone acts as an artificial stress manager. The brain senses it and shuts off the body's own cortisol production. Fludrocortisone mimics aldosterone, holding onto sodium and water while dumping potassium. Watch for a granulocytosis on the antithyroid drugs. Any new sore throat or fever is a red flag, not a common cold. Learn to tell thyroid storm apart from myxedema coma. Thyroid storm is a hyperthermic crisis. Myxedema coma is profound bradycardia sliding into respiratory failure. For corticosteroids, remember the 6 S's of toxicity. Sugar goes up, bones go soft from osteoporosis, sepsis risk rises from immunosuppression, swelling sets in from fluid retention, sight can be affected, and wound healing goes slow. And with fludrocortisone, the real danger is fluid overload and hypokalemia happening together. Give levothyroxine on an empty stomach, 30 to 60 minutes before breakfast, and keep it 4 hours away from calcium or iron supplements. SSKI, the saturated solution of potassium iodide, needs to be given through a straw to protect the teeth. Give corticosteroids in the morning with food, mimicking the body's natural cortisol peak. Never stop a steroid abruptly. That's an Addisonian crisis waiting to happen. Always taper. If a thyroid storm patient reaches for aspirin, stop them. It actually displaces thyroid hormone and makes the storm worse, so acetaminophen only. Hypothyroid patients are extremely sensitive to sedatives. A routine narcotic dose can tip them straight into myxedema coma. Remember the drug split by trimester. PTU is hepatotoxic and required in the first trimester. Methimazole causes agranulocytosis and is used in the second and third. Watch for the spironolactone plus Addison's combination. That's a hyperkalemia trap. Patients receiving radioactive iodine need strict radiation precautions for a full 7 days afterward. Cortisol labs are always drawn at 8 a.m. to match the body's natural peak. And any patient on chronic steroids needs a stress dose before surgery or a serious illness, or they risk a full adrenal crisis. For evaluation, normalized TSH and free T4 confirm replacement therapy is working. A stable heart rate and weight confirm anti-thyroid therapy is working. And stable blood pressure, sodium, and potassium confirm adrenal replacement is on target. Diabetes insipidus versus SIADH. These two get confused constantly, so here's the core distinction. A DH controls a single gate in the kidney's collecting duct. In diabetes insipidus, that gate is stuck open. The body dumps water it can't afford to lose, and sodium climbs into hypernatremia. In SIADH, the gate is stuck shut. The body holds onto water it doesn't need, and sodium gets diluted down into hyponatremia. DI risks hypovolemic shock. SIADH risks cerebral edema and seizures once sodium drops severely. Hypertonic saline for SIADH goes through a central line only on a pump at a tightly controlled rate. Desmopressin for DI needs clear nasal passages to actually absorb. Watch for overcorrection on both sides. With desmopressin, a new severe headache after starting it isn't a sinus symptom. It's dilutional hyponatremia setting in. With hypertonic saline, correcting SIADH too fast strips the myelin off the brainstem, a condition called osmotic demyelination syndrome. One classic trap, sudden, high-volume clear urine right after a craniotomy, is central DI until proven otherwise. That's a medical emergency, not routine post-operative diuresis. Small cell lung cancer is the classic cause of malignant SIADH. Keep that pairing in mind. Lithium causes an entirely different problem, nephrogenic DI, where the kidneys simply stop responding to desmopressin no matter the dose. And remember that vasopressin itself is a vasoconstrictor. That makes it genuinely dangerous in a patient with coronary artery disease. For evaluation, in DI, you want decreasing urine output and a normalizing urine-specific gravity. In SIADH, you want a rising sodium and resolving neurological symptoms. Laxatives speed the belt up, antidiarrheals slow it down, but the highest yield concept here isn't ordinary constipation. It's liver failure. Lactulose traps ammonia in the stool and physically drags it out of the body. Always auscultate bowel sounds before giving anything in this category. Osmotic laxatives carry a real dehydration and hypokalemia risk. Psyllium must be taken immediately with a full glass of water, or it gels up right in the throat and becomes a choking hazard. Enemas are given in the left Sims position. Here's a trap that catches almost everyone. 3 to 4 loose stools a day on lactulose is the drug working exactly as intended. Don't hold it for that. Instead, evaluate mental status and check for asterixis, the flapping hand tremor, to confirm the treatment is actually helping. Never give loperamide for infectious diarrhea. It traps the toxin inside the colon and can trigger toxic megacolon. Never give bismuth to a child recovering from a virus. That's a Reye's syndrome risk. And yes, it also turns the stool harmlessly black, which is not a bleed. Never give a laxative for undiagnosed abdominal pain or absent bowel sounds. You could be pushing against an obstruction. And magnesium citrate is contraindicated in renal failure, since a failing kidney can't clear the magnesium load. For evaluation, lactulose success looks like decreased confusion, not just more stools. And PEG bowel prep success looks like clear or light yellow output. PP is shut the acid pump off completely. H2 blockers like famotidine and cimetidine work differently. They competitively block histamine at the parietal cell, giving a faster onset but a shorter, weaker effect compared to a PPI. Watch for tardive dyskinesia on metoclopramide and QT prolongation on ondansetron. Always check a baseline EKG and correct any low potassium or magnesium before giving it IV, or you're risking torsades de pointe. Watch for anticholinergic toxicity on dicyclomine or scopolamine as well. Give PP is 30 minutes before the first meal of the day. Give sucralfate on an empty stomach, spaced 2 hours away from everything else, since it can block absorption of other drugs. Space antacids 1 to 2 hours from other medications for the same reason. The biggest trap in this section, metoclopramide's dopamine block can cause permanent extrapyramidal symptoms. Stop the drug at the very first sign and never use it in a patient with a bowel obstruction. Long-term PPI use strips away the stomach's protective acid barrier entirely, opening the door to osteoporosis, B12 deficiency, pneumonia, and C. diff. Misoprostol is category X. A negative pregnancy test is mandatory before that first dose. Cimetidine is a potent liver enzyme inhibitor. It spikes levels of warfarin, phenytoin, and theophylline, and it commonly causes confusion in elderly patients. If promethazine infiltrates through an IV, it causes irreversible tissue necrosis. Deep IM is always the safer route. Dicyclomine is contraindicated in narrow-angle glaucoma, BPH, and paralytic ileus, and magnesium-containing antacids are contraindicated in renal failure. For evaluation, resolved dyspepsia, healed ulcers confirmed on endoscopy, and the cessation of nausea and vomiting. Every trap you just heard, the exact thresholds, the exact interactions, is broken down the same way in the full guide on Etsy. Links below if you want it open next to you while you study. Prioritization check. 7 patients, 1 nurse. Pause the video right now, read the list on the screen, and lock in who you would see first. If you chose the NPO surgical patient accidentally given morning glipizide, you saved a life. Sulfonylureas force insulin release whether food is coming or not, and that patient is headed toward a hypoglycemic coma on the table. Here is the breakdown for the rest of the patients on your screen. A patient with hepatic encephalopathy on lactulose having 4 loose stools a day doesn't need intervention. That's the drug working exactly as intended. A patient on long-term high-dose prednisone who just stopped cold is in an Addisonian crisis. Cardiovascular collapse in progress. ASIADH patient on 3% hypertonic saline through a peripheral line, running fast, needs that stopped now. Get a central line and slow it down before the brain pays the price. A hypothyroid patient with a CAD history just started on high-dose levothyroxine, now reporting chest pressure. The accelerated metabolism just outran the coronary supply. A hyperthyroid patient on metamizole with a new sore throat and low fever isn't fighting a cold. The immune system may be gone. And a patient on IV promethazine reporting burning pain radiating up the arm needs that infusion stopped immediately before the tissue dies. Module 6. This is the central nervous system. 2 things make this module dangerous. 1. These are narrow therapeutic index drugs. A small deviation in blood level plunges the patient into toxicity. 2. The brain runs the whole body, so an eye drop for glaucoma can trigger an asthma attack, and a psych med can wipe out bone marrow. 3 universal rules govern every psychiatric medication on this exam. They take weeks to reach therapeutic levels. You can almost never stop them abruptly. Sudden withdrawal means seizures or rebound psychosis. And nearly every class carries an FDA black box warning. First, antidepressants. These drugs don't create new brain chemicals. They turn up the volume on serotonin, norepinephrine, and dopamine by blocking their reuptake. Watch closely for serotonin syndrome. Remember shivers, shivering, hyperreflexia, increased temperature, vital sign instability, encephalopathy, and restlessness. A TCA overdose is cardiotoxic. Look for a widened QRS on the EKG. And MAOIS bring the tyramine trap. Aged cheese, cured meats, wine, a sudden pounding headache, and a stiff neck are the tell. Here's the timing that matters most, the suicide window. Mood takes 2 to 4 weeks to lift, but energy often returns first, creating the highest risk gap where a patient has the drive to act, but not yet the relief. The black box specifically targets patients under 24. Switching between an MAOI and any other antidepressant class requires a full 14-day washout. Fluoxetine goes in the morning, since it can be activating. Paroxetine goes at bedtime, since it's more sedating. And the TCA overdose antidote is IV sodium bicarbonate, not a standard antiarrhythmic. A handful of traps here. SSR is raised GI bleed risk when combined with NSAIDs, and in the elderly, they can trigger SIADH. Sudden confusion in an older patient on an SSRI. I may be hyponatremia, not dementia. Giving an SSRI alone to an undiagnosed bipolar patient can swing them into acute mania. Bupropion lowers the seizure threshold hard, contraindicated in eating disorders, and crushing the extended release form causes dose-dumping seizures. Duloxetine doubles as a treatment for fibromyalgia and diabetic neuropathy. Trazodone carries a real priapism risk, an emergency past 4 hours. And mirtazopine's sedation and weight gain, usually seen as downsides, are actually therapeutic in a frail, anorexic elderly patient. For evaluation, independent ADLs, a stabilized mood without manic or suicidal shifts, and adequate food intake and sleep. Mood stabilizers and anticonvulsants. These drugs don't cure bipolar disorder, they dampen neuron excitability. Lithium competes with sodium and calcium at the cellular level. The anticonvulsants block sodium channels or boost GABA. Lithium's therapeutic range is 0.6 to 1.2 milliequivalents per liter, toxic above 1.5. Early signs are nausea, diarrhea, and a coarse tremor. Late signs are ataxia, confusion, and tinnitus. Valproic acid causes hepatotoxicity and pancreatitis. Watch for right upper quadrant pain and dropping platelets. Carbamazepine causes agranulocytosis, a fever or sore throat. Here is an emergency. And lamotrigine carries a black box for Stevens-Johnson syndrome. Any new rash stops the drug immediately. Lithium requires steady daily sodium and fluid intake. Never restrict salt on this drug. Valproic acid needs regular liver, pancreas, and platelet monitoring, plus strict contraception given how teratogenic it is. The traps here are dense. Low sodium causes the kidneys to hoard lithium, triggering toxicity even without any change in dose, which makes thiazide diuretics the #1 contraindication, and only acetaminophen is safe for pain relief on this drug. Vomiting or diarrhea from any cause, even a stomach bug, can send lithium levels climbing fast. Aspirin displaces valproic acid off plasma proteins, flooding the blood with active free drug. ECT is contraindicated on lithium. It lowers the seizure threshold too far. Patients of Asian descent carry a higher Stevens-Johnson risk with carbamazepine. And valproic acid inhibits lamotrigine's metabolism. Adding a standard lamotrigine dose on top of valproic acid effectively doubles the level. For evaluation, stable mood, a therapeutic lithium level, and no signs of organ toxicity. Psychosis is dopamine running hot. Antipsychotics block D2 receptors to calm it down, but dopamine also runs motor control, so blocking it hard causes movement complications. Watch for neuroleptic malignant syndrome, lead pipe muscle rigidity, a fever over 104, and autonomic instability. The rescue drug is dantrolene. Clozapine destroys white blood cells. The pharmacy is legally barred from dispensing it if the neutrophil count drops. Olanzapine causes metabolic syndrome, and risperidone spikes prolactin, causing gynecomastia and galactorrhea. Run a routine Ames assessment to catch early dyskinesia. Haloperidol decanoate is Z-track injection only. and ziprasidone needs a baseline EKG before starting, given its QT prolongation risk. Every antipsychotic in this class carries a black box warning against use in dementia-related psychosis. Learn the EPS timeline cold. Within hours, you get acute dystonia, a genuine airway threat, rescued with IV diphenhydramine or benztropine. Within days to weeks, you get akathisia, an internal restlessness intense enough to drive suicide. Within months to years, you get tardive dyskinesia, usually irreversible. Tell NMS apart from serotonin syndrome by the reflexes. NMS is rigid and hyperreflexive. Serotonin syndrome is twitchy and hyperreflexive. Giving haloperidol to a Parkinson's patient can trigger a rigid crisis. Use a low D2 agent instead. And chlorpromazine causes photosensitivity and corneal deposits. For evaluation, reduced hallucinations and delusions, no rigidity, no lethal neutropenia, and a protected airway. Next, anxiolytics and sedatives. Benzodiazepines amplify GABA, an aggressive chemical brake pedal on the whole nervous system. Buspirone works completely differently, binding serotonin and dopamine receptors slowly without any CNS depression. Watch for severe respiratory depression and sedation, and for paradoxical agitation in the elderly, where a sedative makes them combative instead of calm. Zolpidem carries a black box for sleepwalking and sleep driving, and this entire class is category D or X in pregnancy. Never taper a benzodiazepine abruptly. That's a rebound seizure risk. IV push for lorazepam or diazepam stays under 2 milligrams a minute, or you risk apnea and cardiac arrest. Dose at bedtime to reduce fall risk. Benzos work in minutes. Buspirone is a slow bus, 2 to 4 weeks to full effect, completely useless for an acute panic attack. Flumazenil is the benzodiazepine reversal agent. Never mix these with alcohol, opioids, or other depressants. That combination causes fatal synergistic respiratory failure. And watch for herbal interactions too. Kava kava and valerian root can cause that same synergistic, dangerous sedation. For evaluation, reduced anxiety, a relaxed posture, a respiratory rate between 12 and 20, and a patient who's easily rousable. When treating substance use disorders, you must know your pharmacological interventions. Methadone and buprenorphine are used for stabilization. They satisfy the opioid receptors to prevent severe withdrawal without providing the high. Naltrexone works differently. It is a reward blocker that stops the buzz and reduces cravings. For alcohol use disorder, disulfiram acts as a physical deterrent. It chemically blocks alcohol metabolism. So, if the patient drinks even a sip, they become violently ill with throbbing headaches and vomiting. The strict rule here, the patient must be completely alcohol-free for at least 12 hours before starting the first dose and must avoid all hidden alcohol, like mouthwash or vanilla extract, for 14 days after stopping. A DHD means an underpowered dopamine norepinephrine filter. Stimulants flood that system back to capacity, restoring focus. Watch for cardiovascular toxicity, vasoconstriction, tachycardia, arrhythmia risk. Severe appetite suppression is a top pediatric priority. Weight and growth need close monitoring. New tics, like sudden blinking or throat clearing, mean hold the drug. Watch for peripheral vasculopathy, cold, pale fingers. Priapism is a genuine methylphenidate emergency. And atomoxetine carries the same suicide black box as the antidepressants. Give these immediately after meals to protect nutrition, since they're appetite suppressants. Cap the last dose by 4 to 6 p.m. to protect sleep. Track growth percentiles closely. Providers often order a summer drug holiday to let a child catch back up. Get a mandatory baseline, ECG, and blood pressure before starting. And mixing these with an OTC decongestant like pseudoephedrine risks a hypertensive crisis. For evaluation, improved attention and impulse control, alongside a stable growth trajectory and heart rate. Seizures are erratic electrical wiring. Phenytoin stabilizes the membrane long-term through sodium channels. Benzodiazepines shut an active seizure down fast through GABA and chloride. Phenytoin's therapeutic window is 10 to 20 micrograms per milliliter. Early toxicity looks like nystagmus and ataxia. Late toxicity looks like slurred speech and respiratory depression. Both phenytoin and lamotrigine carry Stevens-Johnson risk. And levetiracetam's main concern is sedation and suicidal ideation. Phenytoin IV goes strictly in normal saline at a maximum of 50 milligrams a minute. Never stop an antiepileptic abruptly. That risks rebound status epilepticus. Past 5 minutes of continuous seizure activity, you're in status epilepticus, airway first, and IV benzodiazepine second, IV phenytoin third. Gingival hyperplasia is an expected side effect. A new rash is not, that's Stevens-Johnson. And phenytoin destroys the effectiveness of oral contraceptives, so a backup barrier method is required. For evaluation, seizure-free, a protected airway, a therapeutic drug level, and no ataxia or rash. Movement balances two forces, dopamine, which smooths it out, against acetylcholine, which excites it. In Parkinson's, dopamine neurons die off and acetylcholine dominates, producing tremor, rigidity, and bradykinesia. Overmedication causes dyskinesia, grimacing, and twitching. Excess dopamine can also cause hallucinations and paranoia. And orthostatic hypotension is common on these drugs. High-protein meals block levodopa absorption, so protein needs to be spread evenly through the day rather than loaded at one meal. Dark urine and dark sweat are harmless expected findings. Carbidopa is just the escort. It protects levodopa from being broken down before it reaches the brain, but it can't cross the blood-brain barrier itself. Worsening tremor and rigidity means the disease is progressing and needs more drug. Sudden grimacing and twitching means toxicity and needs less drug. And benztropine is contraindicated in glaucoma and BPH. For evaluation, improved motor control, decreased rigidity, and no severe hypotension or dyskinesia. The skull is a locked box. Swelling has nowhere to go but down onto the brainstem. Mannitol pulls fluid out of swollen brain tissue and into the bloodstream fast. That fast fluid shift risks intravascular overload. Watch equally for severe dehydration from overtreatment. Inspect the solution for crystals before infusing, and warm it if needed. Always run it through an inline filter. In a weak heart patient, mannitol risks flash pulmonary edema, auscultate for crackles. Urine output below 30 milliliters an hour means the drug is backing up. Stop the infusion. And a serum osmolality above 320 means hold the drug entirely. Alzheimer's disease means the brain is short on acetylcholine for memory. Acetylcholinesterase inhibitors block the enzyme that destroys it, leaving more available in the synapse. Watch for severe bradycardia and syncope from parasympathetic stimulation, along with GI distress from that same mechanism. Give these at bedtime, since bradycardia and dizziness peak around then, keeping the patient safely in bed instead of upright and at risk of falling. Start low and titrate slowly. Teach families explicitly. This slows the progression of the disease. It does not cure or reverse it. Overdose triggers a cholinergic crisis, remembered as SLUDGE, salivation, lacrimation, urination, defecation, GI cramping, and emesis. And memantine works through a different mechanism entirely, so it doesn't carry that same bradycardia or SLUDGE risk. For evaluation, temporary stabilization of cognitive decline, and longer independent performance of ADLs. Myasthenia gravis is autoimmune destruction of acetylcholine receptors. The same drug class we just covered for Alzheimer's boosts acetylcholine here too, but at the neuromuscular junction instead of the brain, restoring muscle strength. The diaphragm is a muscle, so respiratory effort is the top priority in this population. A cholinergic crisis brings that same sludge picture, with the airway drowning in secretions as the lethal threat. The 30-minute meal rule is absolute. Pyridostigmine goes 30 to 45 minutes before meals, so peak drug strength lines up with chewing and swallowing. A late dose means the jaw and throat muscles can fail mid-meal. Always check swallowability before the tray even arrives. Learn to tell the two crises apart. Myasthenic crisis is weakness paired with dry mucous membranes, not enough drug. Cholinergic crisis is weakness paired with flooding secretions, too much drug. IV atropine is the antidote, and it should be kept at the bedside. For evaluation, improved endurance, resolved ptosis, and safe swallowing. Treatment for glaucoma either turns down the faucet, reducing fluid production, or unclogs the drain, improving outflow. Normal intraocular pressure is 10 to 21 millimeters of mercury. Past 50 is an acute angle closure emergency requiring IV mannitol. Systemic absorption of timolol causes bradycardia and bronchospasm, contraindicated in asthma, COPD, and heart block. Brimonidine can cause systemic CNS depression. Apply punctal occlusion for 60 seconds after every single dose. Drop into the conjunctival sac, never onto the cornea. Give liquid drops before ointment. Space different drops 5 minutes apart, and wait 15 minutes before reinserting contact lenses. Acetazolamide is a sulfonamide, contraindicated with a sulfa allergy, and it causes hypokalemia. Pilocarpine constricts the pupil, which kills night vision. Anticholinergic and epinephrine-based drops dilate the pupil and can actually blind a closed-angle glaucoma patient. Steroid eye drops themselves can cause glaucoma and cataracts with long-term use. Every drug class you just heard is broken down the same way, trap by trap, in the full guide on Etsy. Links below if you want it open next to you while you study. Prioritization check. 8 patients, 1 nurse. Pause the video right now, read the list on the screen, and lock in who you would see first. If you chose the asthmatic patient who received ophthalmic timolol, you saved a life. That eye drop has reached systemic circulation and is actively causing a fatal bronchospasm. The myasthenia gravis patient is a close second, but their airway is drowning in secretion slowly. The asthmatic's airway is clamping shut instantly. Albuterol is needed immediately. Welcome to Module 7. The musculoskeletal system is the body's structural framework, and pain is the alarm system that tells you something's wrong with it. Picture pain as a signal traveling one road, from the finger to the brainstem. Every drug in this module intercepts it at a different checkpoint. At the brainstem, opioids block the perception of pain itself. Also at the brain, but through a different door. Acetaminophen blocks the central pain and fever centers, doing nothing in peripheral tissue. Along the spinal cord, baclofen and gabapentin suppress nerve conduction as the signal travels up. At the local nerve endings, lidocaine numbs the area so the pain spark never starts. And back at the injury site itself, NSAIDs act peripherally, stopping inflammatory prostaglandins from ever forming. Opioids are heavy CNS suppressors: morphine, fentanyl, hydromorphone. In this system, they are reserved strictly for severe acute tissue damage, orthopedic surgery, traumatic fractures, terminal bone cancer, never for chronic mechanical pain like osteoarthritis. The WHO pain ladder: Step 1, mild pain, non-opioids, NSAIDs or acetaminophen. Step 2, moderate pain, weak opioids like codeine or tramadol plus adjuvants. Step 3, severe pain, strong opioids, morphine or fentanyl. Before any Step 2 or Step 3 opioid, enforce the low and slow sedation rules and have naloxone ready. Full respiratory arrest protocols, and the PCA pump rule that only the patient may press their own button. Live back in Module 1's high alert medications. So if you need the deep dive on naloxone's half-life and resedation risk, that's where it is. Non-opioid analgesics, NSAIDs, acetaminophen, aspirin, block prostaglandins right at the injury site. Acetaminophen hits the brain's fever and pain centers with zero anti-inflammatory effect. Aspirin irreversibly blocks platelet aggregation. NSAIDs are intensely nephrotoxic, acetaminophen intensely hepatotoxic. Prostaglandins protect the stomach lining and help platelets clot. Block them with NSAIDs and you get gastric ulcers and internal bleeding. Aspirin overdose overstimulates the CNS straight into respiratory alkalosis. Acetaminophen caps at 4 grams in 24 hours. Ketorolac is IV strength NSAIDs pain relief, but never goes past 5 days total across every route. NSAIDs are category D in the 3rd trimester. Take with food or milk. Percocet and Vicodin carry hidden Tylenol. Calculate the full 24-hour acetaminophen total before adding OTC cold meds or extra Tylenol for fever, or you risk liver failure. In a fetus, NSAIDs, like ibuprofen, close the ductus arteriosus prematurely. Pregnant patients get acetaminophen only. Samter's triad, asthma plus nasal polyps, means a high chance of severe NSAIDs and aspirin hypersensitivity. Celecoxib carries a black box for MI and stroke, and its structure mimics sulfonamides, contraindicated with a sulfa allergy. Salicylism starts with tinnitus, then hyperventilation into respiratory alkalosis. Never give aspirin or bismuth to a child recovering from a viral illness. Ray's syndrome. And watch the 3 Gs, garlic, ginkgo biloba, and ginseng, all inhibit platelet aggregation. Combined with NSAIDs or aspirin, that's a silent bleeding risk. Neuropathic pain comes from damaged nerves firing abnormally. Opioids and NSAIDs don't touch it. Adjuvants stabilize the nerve membrane or physically block sodium channels at the nerve ending, so the signal never starts. Lidocaine absorbed systemically numbs the heart, cardiac arrest risk. Gabapentin and pregabalin cause real ataxia and sedation. Epinephrine mixed with a local anesthetic in the wrong location causes tissue necrosis. Carbamazepine carries Stevens-Johnson and bone marrow suppression risk. The 12-hour patch law: lidocaine patches on for 12 hours, off for 12. Never over broken skin or a heating pad. That forces massive systemic absorption. Never use lidocaine with epinephrine on fingers, toes, nose, ears, or penis. Terminal blood supply. The vasoconstriction causes irreversible necrosis. Duloxetine, An SNRI antidepressant doubles as a primary treatment for fibromyalgia and diabetic neuropathy, and carries the same suicide black box as other antidepressants. Gabapentin and pregabalin for diabetic neuropathy or shingles pain mean fall precautions are the top priority, and carbamazepine for trigeminal neuralgia carries the same HLA-B1-502 genetic trap as before. Patients of Asian descent need screening before the first dose, given the Stevens-Johnson risk. Same joint, 4 different drugs hitting 4 different structures. Muscle relaxants like baclofen and dantrolene stop spasm and rigidity. They do nothing for inflammation or bone density. DMARDs, like methotrexate, halt the autoimmune attack on the joint at the cost of immunosuppression. Bisphosphonates like alendronate halt bone resorption with intense administration rules. And anti-gout drugs like allopurinol and colchicine clear uric acid crystals out of the joint entirely. Rheumatoid arthritis isn't wear and tear. It's the immune system attacking the synovial lining. Intentionally suppress that immune system to save the joint, trading away the body's natural defenses to do it. Methotrexate halts rapid cell division, a drop in white cells, red cells, and platelets. Non-biologics are hepatotoxic. Hydroxychloroquine deposits in the macula, risking irreversible blindness. Biologics can reactivate latent, walled-off TB. Methotrexate for RA is once a week, never daily. Folic acid daily to protect healthy cells. Category X, strict birth control required. Giving methotrexate daily instead of weekly is a fatal error. Complete bone marrow failure within days. Negative TB test required before the first biologic dose. No live vaccines, shingles, MMR. On a biologic or the vaccine itself causes the disease. Blurred vision or trouble seeing colors on hydroxychloroquine means hold the drug. Baseline and every 6 to 12 month eye exams are mandatory. And on infliximab, a mild 100.5 fever isn't mild. The immune system can't mount a normal response. So this is an emergency requiring immediate cultures and antibiotics. Osteoclasts are outpacing osteoblasts. Bisphosphonates paralyze the osteoclasts, halting bone breakdown, but they're highly caustic to mucosal tissue. Severe esophagitis and esophageal ulcers if the pill lodges or reflux occurs. Osteonecrosis of the jaw, usually triggered by dental work while on the drug. Hypocalcemia from suppressed bone turnover. Sit or stand upright for a full 30 minutes after swallowing. First thing in the morning, empty stomach, full 8-ounce glass of plain water. No coffee, juice, or mineral water. Giving this to a bed-bound supine patient guarantees esophageal ulceration. Hold it. Major dental work needs to be completed before starting long-term therapy. Watch for numbness around the mouth or positive Chvostek's and Trousseau signs, hypocalcemia. And oral bisphosphonates are contraindicated in esophageal strictures, achalasia, or severe dysphagia. Those patients need IV zoledronic acid instead. Next, gout. Uric acid crystallizes in the joint, classically the great toe. Treatment splits into 2 phases, resolving the acute attack and preventing future buildup. Using a preventer during an acute attack mobilizes more crystals and makes it worse. Colchicine has a narrow therapeutic index and frequent GI toxicity. Allopurinol carries a real risk of toxic epidermal, necrolysis, and Stevens-Johnson. High uric acid output risks kidney stones. Push 2 to 3 liters of fluid daily to flush uric acid. Avoid purine-rich foods, organ meats, certain seafood, alcohol. On colchicine, severe nausea, vomiting, and diarrhea isn't a normal side effect. It's the earliest sign of multi-system toxicity. Hold the dose and notify the provider. On allopurinol, even a mild flat red rash is a stop the drug emergency, SJS risk. And allopurinol takes weeks to work. It's useless for an acute flare. Colchicine, NSAIDs, is the acute rescue. Skeletal muscle relaxants don't act on the muscle itself. They suppress hyperactive motor neuron firing in the CNS, causing systemic sedation and flaccidity, profound CNS depression, worse mixed with other depressants, hepatotoxicity, specifically with dantrolene and tizanidine. Cyclobenzaprine carries real anticholinergic effects, urinary retention, dry mouth, blurred vision. Taper, baclofen, slowly over 1 to 2 weeks, abrupt stopping, causes rebound spasticity, hallucinations, seizures. No driving, no alcohol, no opioids or benzos on top of these. Malignant hyperthermia is the one exception. A lethal genetic reaction to anesthesia, sudden extreme rigidity, and spiking fever. Dantrolene is the only drug that directly halts the calcium release causing it. Push it immediately. Cyclobenzaprine is contraindicated in glaucoma and BPH because of its anticholinergic load. And baclofen, delivered by an intrathecal pump for MS or cerebral palsy. Any redness or fever at the pump site needs aggressive workup, since it can mean meningitis. Osteoarthritis versus rheumatoid arthritis. Since these two get confused constantly, osteoarthritis is mechanical, asymmetrical, weight-bearing joints, normal labs, and climbs the ladder from acetaminophen, NSAIDs, to a corticosteroid. Rheumatoid arthritis is autoimmune, symmetrical, comes with morning stiffness past an hour, and systemic fever, elevated ESR and CRP, and gets NSAIDs for immediate symptoms, while a DMARD works underneath to actually halt joint destruction. Prioritization check. 7 patients, 1 nurse. Pause the video right now, read the list on the screen, and lock in who you would see first. If you chose the asthmatic patient who took ibuprofen and is now wheezing, you saved a life. That is Samter's triad in action. They are experiencing severe hypersensitivity and their airway is actively closing. The patient on continuous intrathecal baclofen with extreme rigidity is a close. Module 8. Maternity and OB Pharmacology. Every drug in this module has a dual client impact. You are never just treating the mother, you're managing the physiology of 2 patients sharing one bloodstream. We'll move through it in 4 phases: early pregnancy and teratogens, the preeclampsia axis, labor and delivery, and postpartum contraception. Think of the placenta as a filter, not a wall. Tiny drug molecules slip straight through it and can permanently disrupt organ formation while the baby is still being built. Massive, bulky molecules get physically blocked. And because the fetal liver and kidneys are barely functional, anything that does cross builds up to toxic levels far faster in the fetus than it ever would in the mother. Before you give any medication to a woman of childbearing age, look at the checklist on your screen right now. Warpack blind. W. Warfarin is small enough to cross freely and causes fatal fetal CNS bleeding. If a pregnant patient with a mechanical heart valve is on warfarin, hold it, notify the provider, and expect a switch to enoxaparin. A. ACE inhibitors and ARBs block the fetal renin-angiotensin system, causing renal agenesis, the kidneys simply don't form, and fatal pulmonary hypoplasia. R. Radioactive iodine permanently destroys the fetal thyroid, causing lifelong congenital hypothyroidism. P. Phenytoin interferes with folic acid and causes spina bifida. Women on it need 4 milligrams of folic acid daily, well before conception. A. Alcohol causes irreversible fetal alcohol syndrome. C. Chloramphenicol causes gray baby syndrome because the fetal liver can't metabolize it. T. Tetracyclines permanently stain developing teeth and halt long bone growth. B. Benzodiazepines cause floppy infant syndrome. A baby born to a mother on high-dose diazepam will present with profound hypotonia and respiratory collapse. So the priority isn't just watching the mother for sedation, it's having the NICU ready. L. Lithium causes Epstein's anomaly, a malformation of the tricuspid valve. I. Isotretinoin triggers retinoic acid embryopathy, brain and facial malformations, which is why it runs under the strict I-Pledge protocol. 2 forms of contraception, 2 negative pregnancy tests before the first dose, and 1 negative test every month before each refill. N. NS aids in the 3rd trimester prematurely close the fetal ductus arteriosus, causing rapid fetal heart failure. This is why a patient reaching for ibuprofen late in pregnancy needs to be redirected to acetaminophen instead. And D. Depakote, valproic acid, causes severe neural tube defects. 1 postpartum specific trap. Lithium concentrates heavily in breast milk. A bipolar mother stabilized on lithium cannot breastfeed. That's a hard stop, not a dose adjustment. Live vaccines, MMR, varicella, the intranasal flu spray, are absolutely prohibited during pregnancy, but can be given postpartum before discharge, with instructions to avoid pregnancy for 28 days afterward. Preeclampsia is a disease of vasospasm and leaky vessels, triggered by a struggling placenta. The vessels clamp down, blood pressure climbs, and organs start starving for oxygen, while at the same time those damaged vessels leak fluid out into the tissues, so the blood left inside gets thick and sluggish. Right upper quadrant or epigastric pain in a preeclamptic patient is never routine heartburn. It's the liver swelling against its own capsule, and it means HELP syndrome and impending liver rupture. Ankle clonus, the foot beating downward 3 or more times after being flexed, means a seizure is imminent. Magnesium sulfate is the neuroprotector here. It blocks that hyperactive synaptic firing and prevents eclamptic seizures. Watch toxicity with the DURP-DERP ladder. In order, D. Deep tendon reflexes disappear first. U. Urine output drops below 30. R. Respirations drop below 12. And P. Pulmonary edema develops last. If reflexes vanish, stop the infusion immediately and push calcium gluconate slowly over 3 to 5 minutes. Never fast, because a rapid push triggers lethal bradycardia. One trap worth remembering: after delivery, the placenta is out, but the danger isn't over. Toxic anti-angiogenic factors keep damaging the mother's vessels for days afterward, and the seizure risk actually peaks in the first 24 to 48 hours postpartum. So don't discontinue the magnesium just because the baby is delivered. Low-dose aspirin has a completely different job. It's a preventive drug started between 12 and 16 weeks to stop microclots from forming in the placental arteries. It does nothing for an acute hypertensive crisis. If a patient at 32 weeks with new severe hypertension is started on aspirin expecting fast blood pressure control, that's the wrong tool for the wrong moment. For the acute crisis, you reach for labetalol or hydralazine, vasodilators that widen the pipes and drop pressure, but drop it carefully. If hydralazine crashes the pressure too fast, from 180 over 110 to 110 over 70 in minutes, that's not a win. That's collapsed placental perfusion, and you need to check the fetal monitor immediately for late decelerations. During labor, every contraction temporarily clamps the placental vessels shut. Oxytocin strengthens and drives those contractions, but push it too hard and the fetus runs out of oxygen. The tolerance limit is 5 contractions in 10 minutes, or any single contraction over 90 seconds. Beyond that, you'll see late decelerations, and it's time for the uncoil rescue. Unplug the oxytocin, nose oxygen at 10 liters, comfort, turn the patient to her left side to get the uterus off the vena cava, off, give an IV fluid bolus to dilute the drug, and inform the provider. 2 traps that live inside a normal induction. First, oxytocin is structurally almost identical to ADH. It tells the kidneys to hold water and dump sodium. A sudden splitting headache or new confusion during a long induction isn't exhaustion. It's dilutional hyponatremia heading toward a seizure. Second, cervical ripening agents like dinoprostone can never be stacked directly against an oxytocin infusion. You need a 6 to 12 hour gap or you risk uterine rupture. After delivery, the job flips entirely to the mother. The uterus has to clamp down hard to crush those open vessels shut and stop postpartum hemorrhage. Methylergonovine and carboprost do this by force, and both carry a matching contraindication you cannot miss. Methylergonovine causes systemic vasoconstriction, so it's contraindicated in a hypertensive patient. It can trigger a stroke. Carboprost causes bronchoconstriction, so it's contraindicated in asthma. It can trigger a fatal attack. If a postpartum patient with either history is hemorrhaging and the order comes in for the wrong drug, you hold it and notify the provider before it goes in. Once we're out of the pregnancy window, the entire framework shifts. Contraception isn't about fetal safety anymore. It's about managing a chronic prothrombotic state. Estrogen is the master thickener. It ramps up clotting factor production and makes platelets sticky. Watch for it with ACHES, abdominal pain, chest pain, headache, eye problems, severe leg pain. Any one of those in a patient on estrogen is a clot until proven otherwise. Estrogen is an absolute contraindication in smokers over 35, given the stroke and MI risk. Hormonal contraception also depends on a normal gut and liver to work. Enzyme inducers, rifampin, carbamazepine, St. John's wort, burn through the hormones too fast and cause silent contraceptive failure, so patients need a backup barrier method during use and for 7 days after. Gastric bypass patients have the same problem from the opposite direction, malabsorption, so they need a non-oral route, patch, ring, or IUD. Missed pill rules are testable and specific. Miss 1 pill? Take it as soon as you remember. Even if that means 2 in 1 day, no backup needed. Miss 2 or more. Take the most recent missed dose, discard the rest, and use a backup method for 7 days. Miss them in the 3rd week. Skip the placebo week entirely and start a new pack. The progestin-only mini pill is even less forgiving, more than 3 hours late, and protection is lost for 48 hours. The transdermal patch loses real efficacy over 90 kilograms. The vaginal ring is good for 4 months at room temperature, and if it falls out, rinse it in lukewarm water and get it back in within 3 hours. The copper IUD predictably causes heavier, crampier periods. That's expected, not an emergency. Depo-Provera used past 2 years strips bone density, so it needs calcium and vitamin D monitoring. Mechanical barriers like the diaphragm and cervical cap carry 0 systemic risk, but left in too long, they cause toxic shock syndrome. a sudden high fever with a sunburn-like rash on the palms and soles, is Staph aureus, not a normal side effect. One more electrolyte trap. The progestin drospirenone found in Yaz is structurally a cousin of spironolactone. It holds onto potassium. Combine it with an ACE inhibitor, and you can drive a patient into severe hyperkalemia. Muscle weakness and peak T waves are your tell. Before we move to oncology, remember that all the high alert drug lists, teratogen charts, and prioritization tools we're discussing today are fully detailed in the Logical Pharmacology Guide. Check the link in the video description to access the complete digital set. Prioritization check. 7 patients, 1 nurse. Pause the video right now, read the list on the screen, and lock in who you would see first. If you chose the postpartum asthmatic given carboprost, you saved a life. That is a fatal bronchospasm closing the airway. The pre-eclamptic patient shutting down is a close second, but the airway always wins. Here is the breakdown for the rest of the critical traps on your screen. A patient attempting a vaginal birth after a prior C-section on oxytocin, who suddenly reports sharp, tearing abdominal pain and contractions that just stopped. That's uterine rupture, a surgical emergency. A hypertensive postpartum patient given methylergonovine who develops a thunderclap headache and a blood pressure of 210/115. That vasoconstriction just triggered a hemorrhagic stroke. A 37-year-old smoker on combined oral contraceptives with sudden shortness of breath and pleuritic chest pain, pulmonary embolism. A patient on drospirenone and lisinopril with profound muscle weakness and peaked T waves, hyperkalemia heading toward a lethal arrhythmia. And a patient on a 30-hour high-dose oxytocin induction who's becoming lethargic with facial twitching, water intoxication, and impending seizure, not exhaustion. Welcome to Module 9. This module covers 4 different ways of manipulating the immune system and cell division: traditional chemotherapy, biologics, immunosuppressants, and immunostimulants, plus CAR T cell therapy, the newest and highest acuity tool in the box. Each one solves a different problem, and each one creates a predictable, specific danger in exchange. Traditional chemotherapy is a systemic sledgehammer. It cannot tell the difference between a malignant cell and any other rapidly dividing cell in the body. Bone marrow, GI lining, hair follicles all take the same hit the tumor does. Your nursing job here isn't really about the cancer. It's about keeping the patient alive through the predictable collateral damage. 4 drug families do this work. First, alkylating agents like cyclophosphamide. They damage DNA directly. Second, antimetabolites like methotrexate and 5-fluorouracil. They starve cells of the building blocks they need to divide. Third, anti-tumor antibiotics like doxorubicin. Watch out for these, they carry a massive cardiotoxicity risk. And finally, platinum compounds like cisplatin, which destroys the kidney tubules and the 8th cranial nerve. And Vinca alkaloids like vincristine, which destroys peripheral nerve myelin, causing foot drop and paralytic ileus. The shared danger across all of them is bone marrow suppression, pancytopenia. White cells drop and infection risk climbs. Red cells drop and the patient becomes fatigued and hypoxic. Platelets drop and spontaneous bleeding becomes a real risk. Administration has 2 hard rules. These drugs are vesicants, so central line access, a PICC or a port, is always preferred because the high blood volume there dilutes the drug instantly. If a peripheral line has to be used, it must be freshly placed, large bore, with a confirmed robust blood return before a single drop goes in. Here's the trap almost everyone gets backwards: extravasation. If a patient reports burning or swelling at the IV site, the instinct is to pull the catheter out immediately. Don't. Pulling it costs you your only access to the drug that's now sitting in the tissue. Instead, stop the infusion, leave the catheter exactly where it is, aspirate back as much of the remaining drug as you can, push the specific antidote through that same line, and only then remove the catheter and elevate the limb. Cyclophosphamide creates a toxic breakdown product called acrolein that shreds the bladder lining. Hemorrhagic cystitis. The fix is threefold. Give it early in the morning, never at night, push 2 to 3 liters of fluid a day, and administer Mesna, the rescue drug that neutralizes the toxin directly. Have the patient void every 2 hours so the toxic urine doesn't sit and pool against the bladder wall. Methotrexate starves the whole body of folic acid, not just the tumor, so the antidote, leucovorin, has to be given precisely on schedule to rescue the bone marrow from complete wipeout. And watch for doxorubicin heart failure. Rapid weight gain, ankle edema, shortness of breath means stop the drug immediately. A baseline echocardiogram checking ejection fraction is mandatory before that very first dose. because the damage it causes is irreversible. The single highest yield number in this section is the nadir. Blood counts hit their lowest point 7 to 14 days after chemo. In a neutropenic patient at that point, a temperature of exactly 100.4 degrees Fahrenheit is not a mild fever. It's an absolute emergency because that patient has no white cells left to mount anything bigger. Initiate neutropenic precautions immediately. No fresh fruit or vegetables, no fresh flowers, no standing water in the room. And when chemo works too well, you get tumor lysis syndrome. Massive numbers of cancer cells rupturing at once and dumping their contents into the blood. Watch for the TLS triad, hyperkalemia, which risks lethal arrhythmias, hyperuricemia, and hyperphosphatemia, which binds calcium and drops it low enough to cause tetany and seizures. The fix is aggressive IV fluids plus allopurinol to help clear the load. Biologics are engineered proteins, not small molecule drugs, and because they're proteins, stomach acid destroys them completely. They can only be given IV or subcutaneously. They come in 4 families based on how human they are, and that distinction drives allergy risk directly. Chimeric drugs, the ones ending in iximab, like infliximab and rituximab, are part mouse, part human, and carry the highest allergy risk. Humanized drugs ending in zumab carry less. Fully human drugs ending in umab, like adalimumab, carry the lowest allergy risk and are safe for home self-injection. Receptor fusion proteins ending in sept, like etanercept, are their own category entirely. Storage matters here in a way it doesn't for most drugs. Keep them refrigerated between 2 and 8 degrees Celsius. Let them sit at room temperature for 15 to 30 minutes before injecting to reduce stinging, but never use active heat like a microwave or hot water, and never shake the vial. Shaking shatters the protein structure and turns the drug into useless foam. Roll or swirl it gently instead. Run it through a dedicated line with a 0.22 micron inline filter to catch any protein clumps. Because biologics are broken down into plain amino acids by the body's own cells, they completely bypass the liver and kidneys. No dose adjustment is needed for renal or hepatic failure, which is a common wrong answer trap on its own. The infusion reaction trap is the one to know cold, telling apart true anaphylaxis from cytokine release syndrome. If a patient on a chimeric infusion spikes a sudden fever, chills, and mild hypotension, that's CRS, stop the infusion temporarily, give steroids and antipyretics, and restart at half the rate once it resolves. If instead they develop stridor, wheezing, or lip swelling, that's true type 1 anaphylaxis. Stop immediately and push IM epinephrine. Chimeric drugs are premedicated with acetaminophen and diphenhydramine 30 to 60 minutes before infusion, specifically to blunt that mouse protein allergy risk. Before the very first dose of any biologic, you must have negative TB and hepatitis B and C screening in hand. If a patient has latent TB, they start anti-tubercular therapy with isoniazid first, building a pharmacological shield before the biologic ever goes in, because forceful immune suppression will let that dormant infection roar back to life. A few more administration specifics carry real weight here. A temperature at or above 100 degrees Fahrenheit means holding the biologic to prevent fulminant sepsis. If a patient develops stridor or wheezing during a biologic infusion, disconnect at the hub, don't flush the line first, because flushing pushes the drug trapped in the tubing directly into the patient. And if a scheduled subcutaneous biologic dose gets missed, never double up to catch up. Doubling causes critical neutropenia. Give the single missed dose and recalculate the schedule from that day forward. Next, we have immunosuppressants. These drugs turn down the immune system on purpose, either to protect the transplanted organ from rejection or to stop the body from attacking itself in autoimmune disease. And the trade-off is the same every time. Infection risk goes up as inflammation goes down. Calcineurin inhibitors like cyclosporine and tacrolimus cause real nephrotoxicity through afferent arteriole constriction. Antimetabolites like methotrexate carry the same lung risk here as everywhere else. A new, dry, hacking cough is never just a cold. It's the herald sign of life-threatening interstitial pneumonitis, and the drug stops immediately with a chest X-ray to follow. Hydroxychloroquine causes irreversible macular toxicity, permanent blindness, so baseline and every 6 to 12 month eye exams are mandatory. Administration has 2 odd but testable rules. Mycophenolate must be taken strictly on an empty stomach, food blocks absorption, and the capsules can never be opened or crushed. Pregnant nurses shouldn't even handle them. Cyclosporine oral solution binds to plastic and styrofoam, so it has to be mixed and served in a glass container only. The trap that trips up transplant patients constantly. A kidney transplant patient on cyclosporine shows a rise in creatinine. Is that rejection, or is it drug toxicity? You draw a cyclosporin trough level to find out. A high trough means toxicity, so you reduce the dose. A low trough means rejection, so you give high dose IV steroids instead. Same lab value, opposite treatments. Watch the CYP3A4 interaction. Grapefruit juice and macrolide antibiotics like erythromycin block the enzyme that clears tacrolimus and cyclosporin, causing massive kidney-destroying toxicity. And there's a specific crossover trap with gout. Azathioprine is cleared by the same enzyme that allopurinol blocks. A patient on azathioprine who takes allopurinol for a gout flare will see the drug back up and wipe out their bone marrow. The azathioprine dose has to be cut by 75% if the two are ever combined. NSAIDs cause a similar pileup with methotrexate. They compete for renal excretion, so ibuprofen taken for breakthrough pain drives methotrexate to toxic levels. Acetaminophen is the safe substitute. Immunostimulants do the opposite job. They deliberately wake up and hyperactivate the immune system to go hunt down cancer or virus. The nursing mindset flips here. You're intentionally triggering a large controlled inflammatory response, and your job is watching that response stay controlled. Interferons cross the blood-brain barrier and can trigger sudden, severe suicidal ideation, a real psychiatric risk to screen for. Hematopoietic growth factors like epoetin alpha and filgrastim rebuild blood components. Checkpoint inhibitors like pembrolizumab and nivolumab take the brakes off T cells entirely, which makes them strictly contraindicated in solid organ transplant patients because those newly unleashed T cells will attack and destroy the transplanted organ almost immediately. Before starting epoetin alpha, check iron, folic acid, and B12 stores. Without the raw materials, the drug simply has nothing to build red cells out of and is useless. A high fever, severe chills, and body aches after an interferon injection is the expected mechanism of immune activation, working as intended, not infection. Don't hold the dose. Premedicate with acetaminophen instead. But watch the ceiling on epoetin alpha. If hemoglobin climbs above 11 grams per deciliter, the blood becomes dangerously viscous, and the risk shifts to stroke, MI, and severe hypertension. Hold the drug there. Don't chase a normal hemoglobin of 14 to 18. Filgrastim hyperproduces neutrophils and causes expected bone pain. But sudden left upper quadrant abdominal pain or referred left shoulder pain is not that. It's splenic rupture, a life-threatening internal hemorrhage, and it needs a stat provider notification, not analgesics. Checkpoint inhibitors carry their own escalating trap. Because they unleash T cells against cancer, those same T cells can turn on healthy organs, causing immune-mediated colitis or pneumonitis. New watery diarrhea or a hacking cough on one of these drugs is a critical emergency. Hold the drug and start high-dose systemic corticosteroids immediately to stop the body from destroying itself. CAR-T is a one-time infusion of a patient's own T cells, harvested, genetically re-engineered in a lab to recognize their specific cancer, multiplied, and reinfused. The nursing focus narrows to two immediate, high-acuity emergencies that strike in the days after that infusion. Cytokine release syndrome here is a massive systemic firestorm as those modified cells go to work destroying cancer. High, unyielding fevers over 102, plummeting blood pressure, severe hypoxia. The rescue is tocilizumab in the ICU ICANS immune effector, cell-associated neurotoxicity syndrome, is central nervous system inflammation, confusion, tremors, loss of speech, seizures. The rescue is high-dose dexamethasone immediately. The trap worth memorizing here is subtle but high yield. ICANS doesn't announce itself with confusion first. Long before a patient shows disorientation or aphasia, their handwriting degrades. That's why a formal handwriting check, having the patient sign their name, happens every 4 hours post-infusion. Any jagged or shaky penmanship is a critical alert, and it catches the neurotoxicity before full cognitive collapse sets in. Prioritization check. 7 patients, 1 nurse. Pause the video right now, read the list on the screen, and lock in who you would see first. If you chose the patient on IV infliximab, you saved a life. That sudden audible stridor, wheezing, and profound lip swelling is true type 1 anaphylaxis from the chimeric mouse protein. You must disconnect the pump directly at the catheter hub and push rescue IM epinephrine. The post-chemotherapy patient with tumor lysis syndrome showing tall, peaked T waves and a potassium of 7.2 is a close second. That is imminent ventricular fibrillation, needing IV calcium gluconate immediately to protect the heart, but the airway always wins. Here is the breakdown for the rest of the critical traps on your screen. A patient on filgrastim with sudden, severe left upper quadrant and referred left shoulder pain. That is acute splenic rupture, a life-threatening internal hemorrhage. A patient 4 days post-CAR-T infusion with a jagged, shaky signature and acute aphasia, that is impending ICANS. Welcome to our final module. We're closing out this crash course with the two most physiologically vulnerable populations on the exam, Pediatrics and Geriatric. Picture a U-shaped curve of toxicity risk across a lifetime. High on one end in infancy, low in the middle of adulthood, high again on the other end in old age. Two completely different bodies, but the same underlying lesson. Standard adult dosing logic will hurt both of them if you apply it blindly. 4 things make an infant's body handle drugs completely differently from an adult's. The blood-brain barrier is immature and highly permeable, so drugs cross into the brain far more easily. That's extreme neurotoxic risk. The liver's CYP450 enzyme systems are underdeveloped, so half-lives stretch out and drugs accumulate in the organs. The kidneys have small, low-filtration nephrons, so clearance is reduced and accumulation can become lethal. And infants actually carry a larger percentage of total body water in expanded extracellular fluid, which means, counterintuitively, they often need higher milligram per kilogram doses of water-soluble drugs than you'd expect, because that drug has more fluid to dissolve into. Before giving any medication to a child, run the checklist. PVC fact. Promethazine in a child under 2 causes fatal respiratory depression and acts as a severe tissue vesicant if it infiltrates. Valproic acid triggers fatal hepatotoxicity. Ceftriaxone and sulfonamides both displace bilirubin off albumin, causing kernicterus, and ceftriaxone has the added danger of forming a fatal precipitate with IV calcium. Fluoroquinolones degrade articular cartilage and can trigger Achilles tendon rupture. Aspirin triggers Ray's syndrome, hepatic failure with cerebral edema. Codeine and tramadol can cause sudden respiratory arrest because some children are genetically ultra-rapid metabolizers who convert the prodrug into a massive, unpredictable morphine bolus. And tetracyclines cause permanent brown or yellow enamel staining. One more category worth understanding on its own: pooled human globulins, IVIG, HBIG, TIG, RIG. These are concentrated antibodies harvested from thousands of donors, given to provide instant, temporary passive immunity against a severe disease. The catch is that receiving borrowed antibodies blunts the infant's own ability to synthesize active ones, so there's a mandatory delay, often several months, before any live vaccine can be given afterward, to let the borrowed antibodies clear the system first. Now, 3 absolute exceptions where the normal pediatric safety rules get overridden entirely. In Kawasaki disease, the vasculitis causes lethal coronary artery aneurysms. High-dose aspirin combined with IVIG is the only protocol that prevents a pediatric myocardial infarction. And here, cardiovascular survival directly overrides the Ray's risk. In Rocky Mountain spotted fever, the infection itself causes fatal encephalitis and vascular collapse. Doxycycline is the absolute first-line rescue drug, and here, preventing death completely supersedes cosmetic tooth staining, even in a young child. And don't confuse palivizumab with a pooled globulin. It's a lab-engineered monoclonal antibody for RSV prevention in infants, and because it's manufactured, not harvested, it does not interfere with the infant's own antibody synthesis. Scheduled vaccines proceed without delay. A handful of disease-specific sequences carry real weight on this exam. To keep a ductus arteriosus open in a ductal-dependent cardiac defect, you give alprostadil, prostaglandin E1, but it causes profound apnea, so intubation equipment must be at the bedside before you even start the infusion. To close a patent ductus in a premature infant, you go the opposite direction with indomethacin, an NSAID. For cystic fibrosis, pancrelipase enzyme beads are sprinkled exclusively onto acidic food like applesauce, immediately before eating, never crushed, never mixed into milk or anything alkaline, because that destroys the enzyme before it even reaches the gut. And airway clearance in CF follows an exact 5-step sequence, because antibiotics sitting on top of thick mucus do nothing. Albuterol opens the airway first, hypertonic saline hydrates the mucus, Dornase alpha chemically thins it, chest physiotherapy shakes it loose, and only then does tobramycin go in last, into airways that are actually clear enough for it to reach the bacteria. Somatropin, growth hormone, works only on open epiphyseal growth plates. It is completely ineffective once those plates have fused, which is why annual x-rays verify plate patency before continuing therapy. And desmopressin for bedwetting carries a real risk of water intoxication and dilutional hyponatremia. Fluids are strictly restricted after dinner, and a new headache or confusion means stop the drug immediately and check serum sodium. Administration technique in pediatrics is its own high-yield category. IM injections in infants under 7 months go in the vastus lateralis only, the anterolateral thigh, never the gluteal or deltoid muscles to avoid the sciatic nerve. Eardrops flip by age, pull the pinna down and back under age 3, up and back at 3 and older, because the eustachian tube orientation is different. Liquid iron needs a straw or a syringe aimed at the inner cheek to bypass the front teeth entirely since it permanently stains enamel. Give it with vitamin C to boost absorption, and strictly avoid giving it with milk, which blocks absorption completely. Rectal suppositories need the buttocks manually held closed for 5 to 10 minutes afterward, because an infant lacks the sphincter control to keep the dose in on their own. Eye drops go into the inner canthus of a closed eye, never forced into an open one that causes corneal trauma, and the drop naturally rolls onto the conjunctiva when the child blinks. And oral liquids are never shot toward the back of the throat, which triggers gagging and aspiration. Discharge them slowly into the side buccal pocket between the cheek and the gum in small increments. A last cluster of pediatric traps worth knowing: cold. Weight-based dosing math. Take the total daily amount and divide by the number of doses. Don't select the daily total as if it were a single dose. If a calculated pediatric dose ever equals or exceeds a standard adult dose, hold and re-verify. That should never happen mathematically. A crying infant's elevated heart rate and respiratory rate reflect a normal sympathetic surge. Calm the child and get a true resting baseline before holding a high alert drug like digoxin on the basis of a false measurement. And speaking of digoxin, the adult threshold of holding for a heart rate under 60 does not apply here. Hold for under 90 in an infant, under 70 in a child, using a full 60-second apical pulse. A child in shock with a congenital heart defect or with anuria cannot tolerate the standard 20 milliliters per kilogram fluid bolus. That volume causes lethal pulmonary edema in this population. A restricted 10 milliliters per kilogram bolus over a longer duration is the safer approach. A child on amoxicillin for strep who develops a massive trunk rash is very often not having a true penicillin allergy at all. If they actually have mononucleosis, this is a well-documented harmless viral drug interaction, not a type 1 IgE reaction to chard as an allergy. A parent reporting that a prior vaccine caused swelling, crying, or a 101.5 degrees Fahrenheit fever describes a normal immune response, not a reason to delay future vaccines. Only anaphylaxis or encephalopathy within 7 days justifies holding. And if parents refuse the newborn IM vitamin K injection but request an elective circumcision, that procedure needs to be cancelled. Without gut flora yet established to synthesize vitamin K, surgical bleeding risk is fatal. A 10-year-old newly started on fluoxetine for depression is not a blanket SSRI contraindication to question. It's actually the sole FDA-approved exception for children age 8 and up, though it comes with mandatory strict weekly suicide monitoring. And if that same monitoring reveals a child giving away favorite belongings and writing goodbye notes, that is an active, imminent signal of self-harm risk, not benign behavior. A bitter oral medication should never be mixed into a full bottle of formula to disguise the taste. If the infant falls asleep or doesn't finish the bottle, you have no way of knowing how much of the actual dose they received. Mix it only into a small amount, about a teaspoon, of food or syrup instead. And a child in a sickle cell vaso-occlusive crisis should never receive meperidine for pain. It builds up a toxic metabolite, normeperidine, that causes seizures. Morphine or hydromorphone are the safe alternatives. Prioritization check. 7 patients, 1 nurse. Pause the video right now, read the list on the screen, and lock in who you would see first. If you chose the 6-month-old with transposition of the great arteries on continuous IV alprostadil who developed gasping respirations, you saved a life. That apnea is the drug working as expected, and it needs immediate bedside bagging and emergency intubation. The 3-year-old with a congenital heart defect who received a standard bolus and now has crackles is a close second. They are in acute pulmonary edema, but the airway always wins. Here is the breakdown for the rest of the critical traps on your screen. A 9-month-old with congenital heart disease whose apical pulse is 72 before an ordered dose of oral digoxin. 72 is fine for this age group. The adult threshold of 60 doesn't apply, so this dose can proceed. making this a lower priority stable scenario relative to the others. A 4-year-old recovering from a viral illness who was given an over-the-counter salicylate and now has persistent vomiting, combativeness, and confusion, Ray's syndrome, rapidly escalating cerebral edema, and liver failure. A 7-year-old with Rocky Mountain spotted fever whose parents are refusing first-line doxycycline over tooth-staining fears, untreated RMSF, is fatal. Life-saving therapy overrides cosmetic concerns here, and this needs urgent re-education. A 10-year-old 1 week into fluoxetine whose parent reports the child giving away toys and writing goodbye notes, an active suicide risk signal under the black box warning. And a 5-year-old with cystic fibrosis receiving inhaled tobramycin before any bronchodilator or mucus-thinning medication has been given. A sequencing error that leaves the antibiotic sitting uselessly on top of unthinned mucus plugs, therapeutically wasted. In older adults, nearly every one of those pediatric physiological differences runs in reverse. Liver mass shrinks and hepatic blood flow drops, so metabolism slows and half-lives stretch out. Glomerular filtration rate declines, so kidney-cleared drugs accumulate and cause early organ toxicity. And total body fat rises while total body water falls, so highly lipid-soluble drugs sit inside fat reservoirs for far longer than expected, extending their effects long past what the dosing schedule assumes. The Beers criteria is the master list of medications that are disproportionately dangerous in this population, and 5 categories carry the highest yield. First-generation antihistamines like diphenhydramine have intense central anticholinergic activity. They trigger profound confusion, acute delirium, urinary retention, and paralytic ileus, and they're a major driver of fall-related hip fractures in the elderly. Benzodiazepines accumulate in fat depots and produce an exceptionally long half-life here. Daytime ataxia, cognitive collapse, respiratory depression, and frequently paradoxical agitation, where instead of sedation, the patient becomes hyperactive and combative. Antipsychotics carry a mandatory FDA black box warning in this population. They significantly increase the risk of sudden death and stroke, specifically in patients with dementia-related psychosis. Tricyclic antidepressants like amitriptyline combine severe muscarinic blockade with alpha-1 blockade, causing arrhythmias and profound orthostatic hypotension. Strict fall precautions go in immediately. NSAIDs constrict the afferent arteriole, choking off what's coming in. ACE inhibitors dilate the afferent arteriole, letting whatever's left escape instantly. Put those 3 together and filtration pressure collapses completely. Sudden, oliguric acute kidney injury. If a geriatric patient is already on an ACE inhibitor and a diuretic, NSAIDs are strictly contraindicated. If one gets added anyway, hold it, contact the provider, and advocate for acetaminophen instead. Watch for urine output dropping below 30 milliliters per hour, rapid weight gain, and rising BUN and creatinine. A long list of interaction traps rounds out this section. An elderly patient on furosemide and digoxin, low potassium, doesn't just fail to prevent digoxin toxicity, it actively unmasks it, leaving cardiac receptors wide open for the drug to bind unopposed, even at a normal digoxin level. Check potassium, keep it between 3.5 and 5.0. A patient stacking amitriptyline, Benadryl, and oxybutynin is quietly accumulating anticholinergic load across 3 separate drugs. Absent bowel sounds and distension. Here signal paralytic ileus heading toward perforation and sepsis, not 3 unrelated mild side effects. A patient on warfarin started on ceftriaxone or azithromycin needs closer INR monitoring because destroying gut bacteria stops the body's own internal vitamin K synthesis and can send the INR climbing unexpectedly. Long-term PPI use in the elderly isn't a harmless antacid. Achlorhydria from drugs like omeprazole blocks calcium and magnesium absorption and raises the risk of both C. diff and hip fractures. Zolpidem dosing is a classic trap. A geriatric or female patient given the standard adult 10 mg dose has residual drug still active the next morning because of slowed hepatic clearance causing profound ataxia and falls. The correct starting dose here is 5 mg. Levothyroxine in a patient with coronary artery disease follows start low, go slow. A full adult starting dose spikes heart rate and oxygen demand enough to trigger angina or MI prioritization check. 7 patients, 1 nurse. Pause the video right now, read the list on the screen, and lock in who you would see first. If you chose the 1-year-old on alprostadil with absent chest wall movement and cyanosis, you saved a life. That remains the single highest airway priority across this entire crash course. Profound apnea, requiring immediate intubation and mechanical ventilation to survive. Here is the breakdown for the rest of the critical traps on your screen. An elderly patient on a diuretic and an ACE inhibitor who was started on ibuprofen yesterday and now has zero urine output. The triple whammy in progress, oliguric acute kidney injury. A hypertensive 74-year-old on levofloxacin reporting a sudden tearing sensation in the upper back. Collagen breakdown triggering aneurysm rupture or aortic dissection. A 6-year-old recovering from the flu whose parent gave Pepto-Bismol and who is now confused and vomiting. The salicylate crossover trap. This is Ray's syndrome, identical to an aspirin exposure. An elderly patient on chronic lithium who developed viral gastroenteritis and now shows coarse tremor and ataxia. Dehydration-driven lithium toxicity climbing fast. A 78-year-old on polypharmacy with a severely distended abdomen and completely absent bowel sounds. Anticholinergic stacking has produced a paralytic ileus heading toward perforation and sepsis. And a 70-year-old with severe kidney disease who received morphine and is now twitching with muscle jerks. Accumulation of toxic metabolites causing neurotoxicity, needing a switch to fentanyl. That concludes the Logical Pharmacology Ultimate Crash Course. You now possess the anatomical pathways, the high alert safety checks, and the exact clinical logic to dissect the Next Gen NCLEX. Best of luck studying, and I will see you in the next review.